Guardians of Caribbean Health. The vital role of family physicians. Across the sun-kissed islands of the Caribbean, family physicians stand as pillars of their communities. They are the trusted caregivers who know their patients by name, their histories, and their families. These dedicated professionals provide comprehensive medical care throughout their patients' lives. From the bustling streets to the tranquil shores of the Caribbean islands, family physicians are the first line of defense against illness. They treat a wide range of conditions, from common colds to chronic diseases. They are also instrumental in preventative care, promoting healthy lifestyles and early detection of potential problems. The importance of family physicians extends beyond their clinical skills. They are deeply embedded in their communities, understanding the unique cultural and social factors that influence health outcomes. This intimate knowledge allows them to provide care that is both effective and culturally sensitive. In a region facing challenges such as limited healthcare resources and rising rates of chronic diseases, the role of the family physician is more crucial than ever. Their dedication, compassion, and expertise are essential for building a healthier future for the Caribbean. A legacy of care, the Caribbean College of Family Physicians. For over 2 decades, the Caribbean College of Family Physicians, or CCFP, has been a driving force in advancing family medicine across the region. Established in 1987, CCFP is dedicated to improving the health of Caribbean people by promoting and maintaining high standards in general practice. The organization achieves this through education, advocacy, and fostering a strong network of family physicians. At the heart of CCFP's mission lies a commitment to people-centered, continuous care. This approach recognizes that healthcare extends beyond simply treating illness. It's about understanding the individual needs of each patient and providing holistic care throughout their lives. CCFP provides its members with valuable resources, including continuing medical education, professional development opportunities, and access to the latest research in family medicine. These resources equip physicians with the knowledge and skills they need to provide the highest quality care to their patients. Through its unwavering commitment to excellence in family medicine, CCFP plays a vital role in shaping a healthier future for the Caribbean. Its work empowers physicians to be effective leaders and advocates for the well-being of their communities. Global impact, regional action, CCFP's partnership with WONCA. The Caribbean College of Family Physicians recognizes the importance of collaboration in addressing global health challenges. CCFP is a proud member of the World Organization of Family Doctors, or WONCA, a federation of 131 member organizations representing over 500,000 family doctors worldwide. This partnership with WONCA provides CCFP members with access to a global network of family medicine professionals, fostering the exchange of knowledge, best practices, and innovative healthcare solutions. It also allows CCFP to contribute to the development of international standards for family medicine education and practice.
CCFP's commitment to regional action is evident in its active involvement in shaping health policy in the Caribbean. The organization has been instrumental in key health policy meetings, including the Nassau Declaration on Health and the Port of Spain Declaration. These declarations address critical health issues facing the region, such as non-communicable diseases and the social determinants of health. By actively engaging in regional and global health policy discussions, CCFP ensures that the voice of Caribbean family physicians is heard and that the unique healthcare needs of the region are considered.
If you are a family physician committed to improving the health of the Caribbean people, we encourage you to join the Caribbean College of Family Physicians.
CCFP membership offers numerous benefits, including continuing medical education,
professional development opportunities to enhance your leadership skills, advocate for your patients, and contribute to the development of healthcare policies,
research and publications,
global connections.
Join CCFP today and be part of a movement that is shaping a healthier future for the Caribbean.
Together we can make a difference.
Join the Caribbean College of Family Physicians and make a difference. Thank you.
Good afternoon, everyone, and welcome. Welcome from the Caribbean College of Family Physicians. And I will endorse what that video just said. We invite all family doctors to join the Caribbean College of Family Physicians. That is a very beneficial membership organization. So we're here this afternoon to talk about this is the third running of the adolescent seminar, and we're talking about their mental health. Our theme, navigating mental health and ethical challenges in adolescent care, balancing wellness, autonomy, and responsibility. At the end of these sessions, we will have had early on in the year 2 CME credits for mental health and 2 CME credits for ethics. So we just get those right out of the way, and then we can work on the others, right? So welcome, welcome. I am Pauline Williams Eubank Green, better known as Dr. Pauline Williams Green. Keep it short. We're looking forward to a really great session. Is Dr. Anna Brown Morgan with us? Sam? No? All right, so I'm going to lead in prayer. I'm going to ask you to let us stop and give thanks to God. Dear Heavenly Father, thank you first of all for waking us up. Thank you as creator of the universe for recognizing each individual living person here, both here in this meeting and across the globe. We ask you to bless the presenters who have worked hard to prepare their thoughts so that it will be useful for us. Bless us, the participants, who will be seeking to gain knowledge, ideas, thoughts, concepts that will bring us closer to helping the patients we see every day. Thank you for the organizers of this seminar. There's so much involved in making it work. And we ask you to put oil on the wheels of technology and all the things we plan to do and help everything to go safe, to go through well, and so that the delivery will be excellent for our participants. Bless our admin staff who also work so hard. Thank you for their work in the background. Especially now, Lord, bless our families. They have given up, or have allowed us to be participants, presenters, organizers, and other members of staff. We just thank you again and praise you. In Christ's name we pray. Amen. Yes, fellow colleagues, we are at it again. CCFP is presenting their adolescent seminar. This is about the fourth one. All right, so our first presenter, we have changed a little bit because of the just how things go. You know how well we have to just roll with the punches. So Professor, I'm sorry, Anthony, Dr. Anthony Francis.
We remember, Doc, we have the welcome from the president, Dr. Nunez.
Oh yes, I'm so happy. I'm ready to go into the seminar. I forgot. Our president, hard-working Seni Onanuju, is going to be speaking to us in a recorded video. Please go ahead, Sam.
Good afternoon, everyone. Our specially invited guests, Professor Carol James, Doctors Yannick Baldwin Miller, Abigail Harrison, Anthony Frankson, and Wayne Palmer, moderator, Dr. Pauline William Green, esteemed colleagues, friends, ladies and gentlemen, a pleasant good afternoon to you all. It is indeed my pleasure and honor on behalf of the Caribbean College of Family Physicians Jamaican chapter to bring you greetings and welcome you to this, our first webinar for 2025 on adolescent health, part 3B, where we continue our focus on health challenges in our adolescent population. This afternoon's webinar follows on the heels of Part 3A, held on November 28, 2024, where we hope to keep the momentum going as we continue to focus on this special group of individuals, our adolescents. Adolescence is a time when many youngsters begin to experiment with alcohol and other forms of drugs, either because of curiosity, emotional conflicts, or peer pressure. Many of our adolescents suffer from the mental effects that these psychoactive drugs have and may eventually become addicted. Unfortunately, this may carry over into adulthood. Sports participation forms an integral part of many of our adolescent routine activities, while it can and does impact positively by encouraging teamwork, exercise, discipline, and perseverance. It can also have negative impacts, especially when their performance falls below their anticipated expectations. Injuries are particularly significant as the time of occurrence is often unpredictable, as well as the time of recovery and the regression of an athlete when compared to their pre-injury form may be quite significant. Body image has always been long recognized as determinant of self-esteem in our adolescent population. It is highly influenced by the media that promotes unrealistic goals as it relates to body image, and our adolescents place themselves under undue pressure as they more often than not cannot distinguish perception from reality. Irrespective of what aspect of adolescent medicine we explore, we will always be confronted with ethical issues surrounding how best to manage them. They cannot be treated as children as they have passed that stage. Neither can they be treated as adults as they have not yet attained that milestone. The college believes that it is timely that this afternoon we examine ethical issues surrounding autonomy and reporting of substance abuse cases involving our adolescents, as well as how ethics guides the management of our adolescents in competitive sports. The college is pleased to once again bring to the fore some of the health challenges that confront our adolescent population. As such, we have a lineup of presentations to be delivered by distinguished presenters. Dr. Yannick Baldwin-Miller, consultant psychiatrist, Professor Carol James, clinical psychologist, Dr. Abigail Harrison, pediatrician and adolescent medicine specialist, Dr. Anthony Frankson, epidemiologist and bioethicist, and Dr. Wayne Palmer, orthopedic consultant. Doctors Baldwin Miller, Harrison, Frankson, Palmer, and Professor James will welcome you wholeheartedly. A special welcome to our members and all attendees who have sacrificed their Sunday afternoon to attend this webinar. We are immensely grateful. We wish also to welcome all our participants, our presenters, moderator, and attendees, as well as all those who work behind the scene, the IT and technical support personnel, administrator, and the planning committee members whose invaluable support over the years have made webinars such as this a truly worthwhile and successful endeavor. I invite you all on behalf of the college to sit back and enjoy the presentations. Thank you, and God's richest blessings.
All right. Thank you, Dr. Seni Onanuju. And as we said earlier, we've changed up the program a little bit, and we're starting with Dr. Anthony Frankson. Now, Dr. Morton Anthony Frankson is a Jamaican general practitioner, public health specialist, and Caribbean-wide practitioner. He has so many talents, like pretty much most family docs, that he has worked in the United States, the government, the Turk and Caicos Island, and of course in Jamaica. He served with the University of the West Indies as a health research scientist, lecturing in epidemiology, biostatistics, community health, and medical humanities. He is now retired from university, and what did he find himself in? He's now at NCU, where he's the campus physician for that university. True family doctor. And he's also kept his hand in statistics and research. He's the director of those disciplines there. Currently, I tell you, he's so widely talented. He also serves the rest of the Caribbean as the president of the Bioethics Society of the English-speaking Caribbean. And I'm pretty sure he also visits the non-English speaking as well. Almost better than that. So he also continues to serve on a Bureau of Standards of Jamaica Committee, the National Mirror Committee. Sounds very intriguing. Mirror. Dr. Francis is going to present to us on the topic, and let me just make sure I have it here. His topic is ethics of managing substance use disorders in adolescents, balancing autonomy and mandatory reporting. Sounds like an excellent topic to me. Dr. Miller, we will take you after Dr. France. Thank you. Go right ahead, Dr. France.
Thank you very much, Olga. And hello, everybody. I hope you can hear me very well. You can't.
We are hearing you well. I'm hearing you well.
Okay. Sam to upload for me because for some reason I have.
I'm not seeing the presentation just yet. Did you email it to me?
To Holgate Solutions.
Yes.
Email. Yeah, I did that.
Not seeing it yet. 1 second. Let me search.
I might have somehow absolute. However, while that is happening, I can just.
Dr. Frank.
Yes, ma'am.
We may have to reschedule, reshuffle the path, but let's just hear what Sam has to say, and then we'll decide.
Right. So I'm not seeing the presentation in my email. I'm not sure why.
Okay.
We can ask Doc to share his screen if it's not a problem. If it's a problem, then Doc and I will have to connect offline to see if I can get his presentation. So Doc, let's try one more time with the share screen.
Okay. Let's see.
Yeah, perfect. I think third time's a charm. So we click on share screen.
Well, that's because I'm in the IBM thing.
No, I'd love for you to come to Zoom. Let's get out of IBM and let's go to Zoom.
All right.
Zoom itself.
Sam, can we ask Prof. Carol James to present since she was ready?
Sure.
Well, Prof. James, sorry about the shuffling. Can you join? Can you share screen now? Go ahead and share screen, please. Let me introduce you now. All right. Good. I'm sorry about this participants, but you know, the technology, that's just how it is. So we're going to go back to Carolyn James. And while our technical staff tries to sort out Dr. Frankson and Dr. Miller, because I'm not sure if she has shared her screen either. So we're going to go to Professor Carolyn James. Her topic is managing anxiety in adolescents, implications of competitive sports and injury. And that sounds a little detailed for us, GP, but yes, we do see that. We're seeing more and more athletes. Every school now has some competence in a particular sport. So let's talk about Professor Caroline James. She's professor of eating disorders, body image, and mental health. She's a clinical psychologist and eating disorder specialist, as well as an associate dean for the undergraduate studies and student experiences at the Faculty of Social Sciences at the University of the West Indies, Mona. She's deeply committed to improving mental health in the Caribbean through her research and work with her patients. And she has recognized that culture plays a significant role in the way of how patients seek and receive treatment. Professor, could you go ahead, please?
Okay, thank you, Dr. Williams Green. Okay, good afternoon, everyone. All right, let me dive right into the presentation. So sport participation offers the adolescent with various physical and psychosocial benefits. Some of these include physical health, decreased anger, sorry.
Go ahead again.
Are you seeing my screen? Something.
Yes, but it's not. Yes, something's funny. Sam, I think you're not in slideshow, Caroline.
She's in slideshow, but she's in presenter view.
So is it preventing the slides from showing?
No, we're seeing it. It's just that we're seeing your notes as well.
Ah, okay. Let me come out of that then.
Sure.
Okay, is it showing the notes now?
Yeah, it's still showing your notes. So it's the way that you're sharing it. There we go. And then we go to slideshow now.
Okay, all right, thank you.
And now we're good. Yes, perfect.
Okay. All right, so sport participation offers the adolescent with various physical and psychosocial benefits. Some of these include physical health, decreased anger, positive developmental outcomes, increased sleep, a more varied diet, positive effects on depressive symptoms, self-efficacy, and self-esteem. While it has its benefits, there are also risks involved. Injuries are commonly associated with sports, and some of these injuries can be short-term or have long-term implications for the adolescent health. The restoration of physical functioning is often the focus. However, mental functioning often goes ignored. Ignoring mental recovery may result in the following. We may have missed opportunities to address the psychological consequences of the injury, which may be significant. This may cause the adolescent's ability to return to the sport to be quite challenging. It may also contribute to re-injury or even lead to the development of mental disorders. And these challenges have been vastly studied in adult populations. However, when it comes to the adolescents, the research is minuscule. Sport injury is positively associated with higher rates of distress, anxiety, and depression. And the research on the adult population tends to highlight a lot of positive outcomes when it comes to intervention. Little is known about the interventions for the adolescents. So we do need to do more work on our adolescent athletes so that care can be tailored to their needs. So far, the research is showing a rise in psychological distress among adolescents, and the return to sport was primarily affected by psychological illnesses, along with parental and coach guidance through rehabilitation. So my role as a clinical psychologist is to work with adolescents and their support system, primarily their parents, to help them to restore their mental health. The adolescents who I see in my practice are often diagnosed with a mental disorder. When we look at mental disorders, these are debilitating to the adolescent or to anyone who has been diagnosed with it. It causes psychological distress for the individual. It affects their ability to function, to concentrate, to engage in activities that they normally would, and it is outside of the cultural norms. In my line of work, I see a lot of teens with various mental health challenges. Among the top challenges that I've seen in practice are anxiety, depression, eating disorders. And my priority is always to help them to get the tools they need to overcome the mental illness that they face at that given point in time, to reclaim their mental health, and to bounce back stronger than before. My job really is to help them to get back to a 2.0 version of self, where they're able to manage their emotions so they can self-regulate, fully show up, be fully present, and concentrate on what is important to them without the psychological distress interfering with their functioning. This journey towards mental health recovery may take them back to the sport or not. Regardless, I'm with them 100%. So I've spoken about mental disorders. Now I will take a look at mental health. So what exactly is mental health as I'm working with the teens to move towards this direction? So who defines mental health as an absence of clinically significant mental disorder along with optimal state of well-being? However, I do like this definition given by Galsbury, which looks at the internal equilibrium, a state of internal equilibrium and well-being, where the individuals are capable of responding to the demands of life and contributing to their community while actualizing their potential in agreement with social values. So I will be taking you through very brief accounts of 3 adolescents who I've seen in practice who have suffered from sport injury. We'll be looking at their journeys, the obstacles, and victories. So oftentimes when adolescents come to my practice, usually the parents or their coaches will notice that there's a change in how they're functioning. And some of the struggles that they've identified and also collaborates with the research, they've noticed changes in behavior. So a significant shift in mood, irritability, a withdrawal from teammates, friends, loss of interest in the sporting activities. They've noticed decreased performance, so a decline in their performance, difficulty concentrating, sleep challenges, general physical complaints, stomach aches, headaches, unexplained physical pain, academic struggles. So the mental health can affect academic performance, not being able to complete homework assignments, social isolation, so withdrawal from friends and social activities, and changes in their eating habits. So we're talking about decrease or an increase in appetite, as well as changes in weight. So here I'll introduce you to the first case, and all of these are pseudonyms. Laura, 15-year-old track and field athlete. So Laura had sustained an injury from a torn ligament and was out of the sport for approximately 3 months. while she was undergoing physiotherapy. While she slowly reintegrated in the sport, she complained about a lot of or excruciating pain. And despite the practices being less intense, she found that she was dreading her practices. She didn't want to hang out with her teammates, and she was very worried about disappointing her coach as well as her teammates. And also, she had challenges thinking about whether or not she would be ready for champs. My second case, Miguel, 15-year-old male. So during one of his contacts, one of his sporting engagement at football, he broke a toe and continued to play, which worsened his injury. He was taken out of the sport for surgery and recovery. And while recovering, he was placed with the reserve team, which was less intense. His teammates would pressure him to get back into the sport and to get over the recovery. During this time, Miguel noticed some intrusive thoughts that were beyond his control and some compulsive actions as well. And all of this became overwhelming for him. He was later diagnosed with obsessive compulsive disorder, and this affected his ability to play. And my last case, Mary, 15-year-old female football player. She broke a leg while playing a match. During her recovery, her parents noticed that she wasn't herself. They reported irritability, a reduction in her food intake, and high levels of anxiety, along with a compulsion to exercise. She was later seen and diagnosed with anorexia nervosa. So each teen, having been met with the challenge of the injury, they found a solution to cope. Now, the coping strategies that I'll mention here, they're not necessarily unhealthy coping strategies. However, given what the teens had available to them at that point in time, the strategies were unhealthy. So 3 coping strategies were identified. Avoidance coping, usually we use this when we try to escape from a difficult situation or a stressor. Emotion-focused coping, and we would have seen avoidance coping with Laura when she dreaded the games and didn't want to show up for practice. Emotion-focused coping, this is engaging in physical exercise or physical activities to deal with the stressor that they're facing. We would have seen this with Mary, where Mary tried to cope with the emotions that she was experiencing through over-exercising. And lastly, problem-focused coping strategy often comes in the form of goal setting with strategies that adolescents will use to get back to the sport. We see where Miguel, given his thoughts and his obsessions, that prevented him, with him using the problem-focused coping strategies, that prevented him from engaging fully in the sport. So who are we dealing with? So we're all adults on the call, and sometimes I have to even remind parents and coaches that, we have experienced this phase of life or stage of life. And oftentimes people don't remember what it's like to be an adolescent. So it's important to go back to the context. So the adolescence can be a period that's tumultuous. It can be characterized by heightened emotionality, identity concerns, and self-regulation. Unlike adults, adolescents tend to experience more mood disturbances, and their pain tolerance is far less. You'll find a lot of catastrophizing and anxiety among the adolescent. Now, for those who identify strongly with the athletic identity, once there's an injury, it causes a lot of depression or depressive symptoms, high depressive symptoms for the adolescent. However, for some who have the social support, it has been known to lower the initial depressive symptoms. So if you put all of this in context, we understand that the injury-related difficulties that adolescents face in this phase, they're not surprising. Mental disorders are not uncommon during this phase of development. In fact, you're likely to see its manifestation here because of some of the challenges or some of the developmental challenges that the adolescent would have faced that I mentioned early on. Research has shown that between 10 to 20% of adolescents are affected by a mental illness annually, and mental disorders account for 15 to 30% of the disability-adjusted life years lost in the first 30 years of life. And anxiety disorders account for a large proportion of the burden of the disease among all mental health problems. They affect and are present among adolescent athletes, and they require greater attention. In the prevalence studies, they've seen a higher prevalence of anxiety among female athletes when compared to male athletes. What they've also noticed in the research is that you have an increase in anxiety among female athletes, still higher among female athletes than male athletes, but the anxiety levels were far higher when compared to pre-COVID. So my role in action, really my job is to help adolescents to understand how their brains operate and to take a more non-judgmental approach to loving their brains and how it is engineered. So in order for them to make the changes and to, transform the adversities that they face, they really have to work on becoming more conscious. As human beings, our levels of consciousness tend to be driven primarily by the unconscious. So oftentimes we're not even aware that there are factors that have affected us because we're spending less mental energy focusing on those factors. Usually we forget about those factors. But if you look at this iceberg, you'll notice that a large majority of the unconscious tends to be present and drives our actions. My job as a psychologist is to help the adolescents to become more aware of the unconscious mind and the role that it plays. So oftentimes when we're labeling what's going on in the minds of the adolescent, they often feel like this is their aha moment. It's their conscious moment where they become more aware of their mental struggles. So psychoeducation is very important in my line of work. And here I'll take the adolescent through the emotions that they experience, the nervousness, the pressure, the stress, which are all common experiences in sport. At moderate levels, you do need this in order to excel. But what happens when nervousness intensifies and it goes beyond the distress tolerance, when there is full-blown anxiety? Here, the adolescent experience paralysis, and it inhibits their optimal performance. So when we look at the diagnosis of anxiety, it goes beyond just being nervous or anxious. It is excessive fear or anxiety that occurs frequently for the past 6 months. Here we see where the individual struggles with worrisome thoughts, so their cognitions are affected. Physically, they're affected, so examples would be heart palpitation, and behaviorally, they're affected. You'll see examples of avoidance. And usually the symptoms can affect concentration and their ability to perform. And it may also affect other areas such as home, school, and relationships. So let me introduce you to anxiety.
Orange? Who made the console orange?
Do I look orange?
I didn't touch it. Orange is not my color.
Hello, everybody. Oh my gosh, I am just such a huge fan of yours. And now here I am meeting you face to face. Okay, how can I help? I can take notes, get coffee, manage your calendar, walk your dog, carry your things, watch you sleep.
Wow, you have a lot of energy. Maybe you could just stay in one place.
Anything. Just call my name and I'm here for you.
Okay, love that. And what was your name again?
Oh, I'm sorry. I can get ahead of myself. I'm anxiety. I'm one of Riley's new emotions, and we are just super jazzed to be here. Where can I put my stuff?
What do you mean we?
Okay. So if you haven't
Orange?
watched Inside Out, I would strongly recommend it, especially if you're working with adolescents, because there you can help them to identify and understand the different emotions. So usually when we talk about emotions, I talk to teens about understanding the relevance of this, because this helps you to connect with your personal experiences. So anxiety isn't the enemy here. It's the strategies that we use to manage anxiety. If we don't have anxiety, then we can go into dangerous situations and it will cause a lot of problems to us. So imagine if you didn't have anxiety and if I were to send you to go to the middle of the street with moving cars. So you can see where anxiety is there to protect you as the emotion that signals danger. So in our journey to facing anxiety and finding tools to manage anxiety, I take the teens to the processes that we'll be using. And this is a diagram that was created by Russ Harris. And I use it a lot in my practice. So at the very center, it is what the teen is accustomed to. Remember those coping tools that I mentioned early on, or the coping strategies, the avoidance that Laura had used, the emotion focus, the problem-solving focus. Here we start at the beginning, and I'm going to use Laura as an example, where she's avoiding practicing because when she gets into the game, it causes a lot of anxiety for her. So here we work on strategies for her to move out of what is familiar to her to move to the fear zone. When she moves to the fear zone, I'm preparing Laura to know that this is an unfamiliar zone for her. And this is okay for her to feel uncomfortable. But the more she stays in fear, and if she trusts the strategies that I'm working with her on, then what she will realize is that eventually she will gain the confidence to realize that fear isn't there to take over, isn't there to damage her life. But with a deeper understanding, she will get to a place of learning to manage it. And by learning to manage it, she will gain the confidence. She will realize that she's the one who is uncovering the strategies and using the strategies to help her to cope with the anxiety. And later on, oftentimes when I bring teens to the learning zone, they want to go even further. So they'll ask for more challenges and they'll move to the growth zone. So here they're living big dreams, they're discovering their true purposes, etc. So though anxious thoughts are unpleasant, there are skills that athletes can use to develop them and to spend less time worrying about them. Here I help adolescents to work on identifying the thoughts and normalizing the thoughts that are being generated because of the injury that they have experienced. So adolescents tend to share with me having worries about making mistakes, feeling embarrassed, letting others down, being in the spotlight, others watching them, experiencing uncomfortable physical sensations associated with the anxiety, and being worried about getting injured or how they will perform. Here I implement thought diffusion. So while we look at the brain generating the different thoughts, we're able to realize that we aren't our thoughts. While our thoughts may take over our perceptions, we can create a separation from our thoughts observe our thoughts, acknowledge our thoughts without fully believing and playing out our thoughts. Another strategy that we use, and oftentimes this comes up, where the adolescent, in as much as they're driven and they're determined and they're very disciplined, will find that the inner critic tends to play a role. And the inner critic is what you would have developed as you're going through the different phases from childhood. You're getting information about the rules of society. Your parents are telling you about the expectations. And while this is important because it helps you to, show up for a match, to participate, to be a team player, etc., there are times when the volume of the inner critic can be quite loud. So while we're not trying to get rid of the inner critic, we have to find strategies to manage the volume of the inner critic so that we can focus on the game. So here, we help adolescents to label, understand, and manage the inner critic by turning down the volume. Another strategy that we often speak about is the unhelpful and helpful strategies. So there's no shaming in what the brain has engineered to cope with the particular strategy. So we have unhelpful strategies. So we'll explore with the adolescents, looking at what it is that the brain is suggesting. So putting pressure on self to perform, self-criticism, worrying about the physical sensation of anxiety, and then we create some helpful strategies. So being able to focus in the present moment, to enjoy the sport, developing positive self-talk and reframing the focus of attention on their skills, and breathing exercises. There are other intervention strategies that we tend to use. And I've listed them here. I'm not going to go through them in the interest of time, but you have relaxation, mindfulness, being present, imagery, goal setting, taking autonomy or control over what you can, and, leaning on teammates for support, as well as communicating openly. But there are some key, social support is key. And there are some key members in the social support that the adolescents need. We need the parents, we need the coaches, the pediatricians, mental health providers, sports psychologists, and physiotherapists. So where are they now? Remember when I mentioned about Laura, Miguel, and Mary? So in terms of their own progress, so Laura has changed sport. She now does swimming and has made peace with her track and field days. Mary has stopped playing altogether. She's fully recovered from anorexia nervosa and is focusing her energies on furthering her education. Miguel continues to play and thoroughly enjoys his sport. Now that he has OCD under control, he has become more invested in the workings of his mind. If you remember that diagram that I showed you at the very end where you have the growth zone, Miguel spends a lot of time there, like challenging himself and learning new techniques of managing his mind. So here are some references that I've used for this presentation. And that's the end of my presentation. I'd like to thank you.
Thank you so much. And your timing is excellent. And I just want to lift my hat to the psychologist. Professor, you have timed it well, and you have hit home at such key points. You didn't use the term emotional intelligence, but you certainly talk about heightening the teens' emotional intelligence. And that is how I would summarize it. I'm going to allow questions to you directly now so that we can, hear some thoughts. We're really impressed with this presentation. Are there any questions? Please put them in the Q&A. And just a word to those who require CME certificates, by the very fact that you signed up you paid for this CME event, you will get your 2 hours of ethics, 2 hours of mental health. So we see all the congratulations going up there. I would, while we see the question, Sam, could you check for me in question and answer? Let me just ask a little bit more. Can you say a little bit more about using anxiety or in Miguel's case, the OCD, educating them and carrying, what is this process like and how long does it usually take? Is there a time frame that get to say to the team, this is going to take 6 months or whatever? Please help us with that.
Yes, so the time frame is dependent on the teen, like their level of understanding as well as their level of investment. So usually for some teens like Miguel, Miguel was fully invested. So it took him around, I would say 2 months to really get to a place of developing the tools to work on his OCD. And the strategies that I spoke about with Miguel really has to do with while OCD is a mental disorder, it is important to understand that the brain that created these unhelpful strategies still has the positives. And so for Miguel, his attention to details, his drive and determination, if we put it in his OCD, then it becomes unhelpful. But if we put it in strategies that he can create, like mindfulness experiences, as well as being present or goal setting to make sure that he takes care of his physical health, so showing up for physiotherapy, etc. If he uses the same strategies that he used with the OCD to better his mental health, then it will be more helpful for him. So when I mention not knocking what the brain has recommended, that's what I mean by not knocking it.
Thank you very much. Right, so that's highlighted it. Let me see, going to look in the Q&A. I'm not seeing any questions. Wow.
None at all. I think the presentation was that good.
Excellent. Could you tell us, you mentioned your practice, and as GPs, Professor James, we would be very interested to make use of your services. Can you help us with that?
I can email that to you because UE is my full-time job. So my private practice, the spaces tend to be limited, and
Yes.
my primary focus is usually on those who suffer from eating disorders. And if I have other slots, then and I'm able to fit other teens, then I'll do that. But I can email you my information.
Thank you very much. Or would you put that in the chat?
I can put it in the chat, but I'll caution.
Address.
Yes, I'll caution people that I may have to refer them to other psychologists given the slots that I have.
Understood, and we appreciate why. You are so clear and lucid, and as for that little cartoon, we loved it. Really to make the point, and I'm sure your teens love you as well. Thank you so much. You really did an excellent job in helping us understand what teens go through when they go through an injury or any similar trauma that affects their performance, and how you address it. Thank you so much.
You're most welcome. Thanks for having me.
Great. So now we're going to move on to our next presenter. Who are we using? Who is presenting now, please? Sam, I'm dependent on you.
It's up to you, but I do have the presentation for Dr. Franks, and since you already introduced him, we could just go ahead.
Right. So we'll go ahead with our GP public health specialist, statistician, researcher. Please go ahead, Dr. Franks.
Thank you very much, Amelia Green. Thank you, everyone. Is that at full screen? Full view? Screen view?
Yes, it is.
Looks
Are you
like
seeing it
it.
full screen? Yeah.
Okay. All right. I'll just keep saying next when you change. All right. You have heard our title for this evening study. It's a privilege to be invited. And I am hoping that what I say will complement those wonderful points of all our other already excellent and anticipated even continued excellent presentations. Next. Next, please. Okay, I have no conflict of interest, but I have several complementary interests. For years, decades, I've been a health and temperance promotion advocate, and I've worked both with religious organizations as well as with organizations on the social and governmental nature, such as when the National Council of Drug Abuse was established in 1983. One of the things that they had was a Parents Support Committee, and I was the first chairman of that Parent Support Committee back when the world was a little bit younger. And throughout the years and presently, my emphasis is on advancing wholeness on the campuses of tertiary education institutes, because those are some really intense environments, and oftentimes enroll in them young and vibrant, and by the time 4 or 6 or 8 or whatever number of years are finished, they actually leave us in poorer health. So I'm hoping that we could reverse that trend so that the vibrancy that came into our various tertiary institutions, we could even leave with even better vibrancy as we go on. And the vital thing in that all is charity. Next slide, please. And the Bible gives us a lot of good help there that all could agree on. Love, peace, joy, forbearance, kindness, goodness, faithfulness, gentleness, and temperance or self-control. A lot was said about self-control in the last presentation. The Bible Paul likes to remind us that all of the wonderful things, faith, hope, and love, the greatest is love. And we use that in caring for each other. And one of the beautiful things about love is that it has been one of the driving forces of ethics, because it inspires justice, and thereafter they become inseparable. And justice helps to, next slide, please. Justice helps us to see that we really are treasures of God, and he's a very just as well as loving God. And I like this Psalm 82, verse 6, which says, all of you are God's children of the Most High. It's lowercase g for God's, in the sense that we have been given delegations of what God has in running the universe. We have been delegated to be psychiatrists and general practitioners and judges and lawyers and teachers and so forth. And we all have to make such important decisions that we are actually doing them on behalf of God and with God's guidance. So if you want to tie that with Matthew 9, next, come back to that other slide. Yes, if you want to tie that with Matthew 7, verse 12, the admonition is there. So in everything, do to others what you would have them do to you. This is a sum of how you really run the kingdom that is at your disposal. No killing is permitted, whether indirectly or intentional, and anything that will kill us, we should consider it an enemy. Indeed, one of the treasures that we learn from that good book is that as 1 Corinthians 3:16, 6:19 to 20, and 2 Corinthians 6:16 to 18 reminds us that our body really is a temple. Next slide, please. And so my mission here this evening is consider ethical implications when addressing substance use disorders, addiction, other side effects, and intervention strategies, including mandatory reporting. Next slide, please. A substance is really a harmful or hazardous chemical, and it has psychoactive properties. The most popular of them is alcohol and several other illicit drugs as well. Next slide, please. All of these help to steal away and knock at and diminish our will, our subconscious, as well as our conscious components. So we find that they deprive us of the ability to govern ourselves and even to respect governing other people's ability to govern themselves. They really, a good life should leave you not having any harm done to you. And really, when we interact with others, because of the love that we have for them and the treasure we have of them as temples, we should be providing no harm to them as well. In fact, what we should be providing is benefits abundantly. Beneficence, and I mentioned already, justice, which goes with love. Well, Johns Hopkins University has some concerns that helps us to understand that our client is in trouble when they're having substance use disorders. If they're using or drinking large amounts or over long periods of time, longer periods of time than planned, they're continually wanting or unsuccessfully trying to cut down or control the use of drugs or alcohol. If they're spending a lot of time using and recovering from the use of drugs or alcohol, if there are cravings that they are really having a battle with and strong desires to use drugs or alcohol, if there's ongoing drug or alcohol use that interferes with work, school, or home duties, indeed, if using drugs or alcohol, even with continued relationship problems, are caused by use, if they're giving up or reducing activities because of drug or alcohol use, they're taking risks such as sexual risks or driving under the influence, they're continually using drugs or alcohol, even though it is causing or adding to physical and psychological patterns. They're developing tolerance to or need to use more drugs or alcohol to get the same effects, or using the same amount of drugs or alcohol, but without the same effects. If they're having withdrawal symptoms, if not using the drugs or alcohol, or using alcohol or other drugs to avoid symptoms, and if they're putting others at varying levels of risk as they use these substances, there is a problem, and it becomes something that ethics must mitigate. Next slide, please. And when substances are used, there are some seemingly positive things. People get high. There's a warmth, there's an excitement, habituation or craving, however, may happen. And with that, they might find that they are affecting their lifestyles, even to the point of affecting their nutrition, leading them at any age or stage, protein, energy, malnutrition, etc. Then that's one of the effects. That's one of the sets of effects of substances. The other four bulleted points are really unpleasant and, in fact, even deadly side effects. Disorders, disorganized thinking, memory loss, mental disorders, organs such as your brain, your liver, your lungs, etc., damaged, and damages to the unborn if the person is carrying a child. Drowsiness, dizzy, agitated, blurred vision, slurred speech, lethargy, slowing of reflexes, muscle weakness. These are some of the effects. And they continue. The one that is on for every drug that you can pick up on the white sheet that you look at, nausea and vomiting. but it can even be worse than that. It can be arrhythmias, heart failures within minutes of even the use one time of some drugs, numbness, unconsciousness, death. Next slide, please. These that I've listed so far depend on the substance that we're talking about. Cocaine will have a different effect from alcohol, from marijuana or ganja, or the phytocannabinoids, etc. Right down to ecstasy. Completely different effects sometimes. It also will be modified by how frequently it is used and the length of time since it was last used. Next slide. Next, thank you. And these things tell on us so that we can look and make diagnoses in this when we see weight loss, continual fatigue, red eyes, little concern for hygiene, abnormalities in laboratory tests when we do those extra investigations, unexpected abnormalities in the heart rate or blood pressure, depression, anxiety, or sleep problems. Next slide. Slide, please. And these are things that we who are challenged to report these things and deal with them and intervene, we the diagnosticians have to face. And such diagnosticians or reporters are family and general medical practitioners, psychiatrists, other qualified mental health professionals, and others like pharmacists, teachers, coaches, etc., are all sometimes ones who might find themselves in a position to report. Let's go on, please. Next. So the substances that are under consideration are listed here. Your alcohols, cannabinoids, pain pills, anxiolytics, cocaine, opiates, methamphetamine, hallucinogens, including lysergic acid diethylamide, otherwise known as Lucy or acid, with its intense effects on our thoughts, emotions, and sensory perceptions, psychedelic, mystical, or spiritual or religious experiences, and all of that. And then, of course, there are the inhalers. And, you know, they are volatile, extremely toxic substances that have intoxicating chemical vapors, and you can be huffing or bagging, chroming, as you huff them through your mouth. When you take them through your mouth, it's called huffing or bagging or chroming, or you can take them through your nose. Oh, sniffing or snorting or spray paint, correction fluids, felt tip markers, glues, cleaning fluids, gasoline, degreasers and gases of different kinds, anesthetics. Sometimes are shuttled off, halothane or whatever, and even refrigerants, propane, nitrites, otherwise known as poppers, are even sold in small vials that help to have a drastic effect on the blood vessels. These are things that are not as uncommon as you might think. Next slide. Next slide, please. And for example, 4% of adolescents, 14 years old and so forth, were found in some countries to use this, country near to us. Next slide. Next slide, please. Have I lost? You're going to connection lost.
Are we having problems with the slide? Sam, slide hasn't moved.
I will go on talking while that happens. when he catches up with
Sorry about
that.
that. It froze, but the slides don't change. We're now on the principalism slide.
Not showing on the screen though.
It's not
And
not showing, Sam.
okay.
Apologies. Let's reshare.
Yeah.
Yeah, there it is. That's right.
Seeing it now?
No, but
Waiting
I'll go
for
on
it.
talking until I see it. Principalism is one of the ethical approaches that one could use. We need to go up a little bit more. Yes, but principalism is one of the philosophical approaches that one could use to sort through this matter. I've defined it earlier, and these principles of ethics are well known to us. Nurses have even more principles than these: veracity and truth telling and fidelity and so forth. But these are the ones that we as physicians usually stuff things into that we can. Next slide, please. So that's one way of looking at things. And another way of looking at things is, that way, by the way, is a very top-down approach. You decide what principles you're going to use as filters and then look at the issues through those filters. Well, you may want to go home and read Matthew 23:16-22. It really isn't directly related to today's lecture, but the next slide, please. It does show something very interesting that is available to us for our consideration. And Jesus ran into it. It's one where you should really use a bottom-up approach many times in solving some of these issues that we have to deal with. And this bottom-up approach is called casuistry. Of course, there are two forms, and the second form of unsound reasoning is really what that Bible text was showing, that Jesus was having a problem with some of the misplaced emphases that people put on certain things because they want to argue to continue using those things because they're working to their convenience, it seems, but that is not a healthy thing to do. And it is one way of using the word casuistry. But the way that I would want us to use it this evening, as we sort through the issues of under consideration, the first one of resolving of moral problems by pragmatic application of theoretical rules, has a strong Judeo-Christian underpinning to it, and it is oftentimes used by health committees to analyze ethical issues surrounding specific patient cases, such as agreeing on the severity of a problem or what is the likely best solution according to others' experiences. So bear that word in mind, casuistry, as we go on. Next slide, please. And are the slides frozen again? There we go. Yes, the thing about casuistry and applying it is that it has two major components where and the idea is that you're trying to look at a particular case. There's a particular patient who has come with, or an adolescent, for example, who has come with a drug problem, and you could use the principles-based approach, but a more natural approach might be to start to reason through what you have right in front of you from that particular case and try to apply reasoning to it to the other similar cases that might have happened, maybe not even exactly with that particular kind of drug or etc., but applying principles that were used previously and there is precedent in, and it worked. And it therefore becomes a paradigm that you want to try to fit this present case that is in front of you into. So what you engage in is a process of ethical analysis, and you begin by identifying features. Identifying features of both a specific case at hand instead of using an abstract principle. And then you look at the precedent to see which ones are reasonably similar cases. And then the next component, the second component, is then apply ethically related findings from the analysis to the case at hand. And hopefully with the input of others as well, see that you actually have a better appreciation of what are the moral issues related to the case that you have. For example, to respect a substance using adolescents referral of life-saving interventions to one could look to similar cases in the past for basic guidance. And notice I use the word guidance, since when you're looking back at those cases, they might have happened in resource-rich countries, they might have happened in urban areas, whereas this adolescent in front of you is from a rural area. They might have happened in maybe for folks with other attendant disorders, etc. And so you have to contextualize it and really use your judgment. And then you judge with this enlightened insight the best way forward for a particular case that is at hand. Next slide, please. And it's not a perfect method. It's not a perfect method, but neither is principalism. But it has its merits. But some of its setbacks are that if we have a situation where not all the people can agree on how the precedent cases principles from them should be applied to the present one, then you might have an ill fit there of fitting a square peg in a round hole. And sometimes that can be a problem that needs to be worked out. It's not forward-looking enough to give guidance about ethical issues in scientific innovation. So when we're talking about research, we usually go to the principle-based approach, that when we're talking about research and ethics and so on. And certainly we're doing research on adolescents and substance use, we might gravitate towards that. However, in a patient care setting, you might want to start with the issues facing that patient and then also use a CASRIS approach. And it has its limitations in other applications in healthcare as well. Some of our cutting edge technologies. Next slide, please. So some of those things that you might want to do with that patient are your possible interventions would be substance-specific interventions. How you would treat a smoking problem is different from how you would treat a problem from popping of pills, etc., etc. And the chemical nature and the pharmacokinetics, pharmacodynamics that is involved. You also have to do follow-up as a possible intervention after the long-term or short-term interactions with your patients and your adolescent clients. And you might therefore be focusing more on the long-term effects, shooting for that, or focusing on present outputs, what you have to do, what are the present busy things that you have to do. So much of so on should be done, so many visits should be made, and so on and so forth. When you're looking more at outputs, it's a little different from when you're looking at outcomes. And you might include formalized group meetings. These are usually long-term ones. Psychosocial support systems are absolutely important in most cases as possible interventions. Detoxification may be necessary, and when it is, it should be seen as one. Psychotherapy focusing on contributing and resultant issues is also a possible intervention. And reporting comes in as an intervention. And of course, there needs to be if necessary, continued medical supervision as something that is not just possible, but necessary. Next slide, please.
4 minutes left, Doc. 4 minutes left.
Okay, no problem. I want to let you know that in Jamaica, we do not have a well worked out referral system for adolescents with drugs. We have laws that are more so for Child Protection Act laws, protected disclosure laws, access to information laws, and your data protection acts and so forth. But really, what we need is to get more on that. When I called the Ministry of Health and Wellness, they told me that initial efforts towards making clear policies in that have not yet panned out. But we can learn from, using a casuistic approach, we can learn from, for example, the child abuse ones that we have for reporting. The principles they use are who, how, when, what, and so forth. Next one. Next slide, please. Who? Mandatory reporters is who. And they are examples of them are listed there: healthcare providers, educated, mental health workers, law enforcement officers. And please bear in mind, not all persons are mandatory reporters. Next slide. When, as soon as possible, if there's a suspicion of abuse or neglect. Next slide. How? What is usually done is to directly report to some law enforcement agency, some responsible agency or child protective service or practice that is dedicated to addressing that particular substance abuse issue. And usually any reporting is done within the jurisdiction where the whole thing has been discovered. And next slide. What is, make sure that the name of the person, the date of birth and the address and other pertinent information goes along with the reporting. All of that is helping to be very respectful of the person and also inviting of justice. And make sure that when we are doing these reportings, we remember that what we're doing is we are reporting people not punitively, but we're reporting so that they will get better, so that the problem will be stopped as best as possible. That should be our intent. That's where the charity and the long suffering and so on come in, because these are not easy maneuvers as we try to get young people well. Move on to the next slide, please. And follow-up reports come after an initial call, and the submitting of a formal report should be within 2 working days of the initial call. Next slide. And really, it is tricky. The business of this all is tricky. There are potential consequences of an intervention that you might be reporting them and guiding them towards. And what we need to do is to really be the advocate for the patients and prioritize the patients versus the public's welfare. And we should work to prevent any harm to survivors who might be involved in the whole thing, including the patient. And depending on the situation, it might even be best not to take any action right away. I should really put 3 dots there, ... We need to seek guidance willingly from our supervisors. Ask for more information from the clients and ask for more information from our supervisors and other mandatory reporters, because they will also have wisdom to impart in this. All of this brings beneficence to the whole thing. Because we're using a casuistic approach, we haven't thrown away the principles-based core elements, but we're just going from the bottom up to establish those principles. Moving on, please. And I want to leave you with, as we come to some, or almost at the end now, we 3 C's that we have to face with adolescents. We have to contend with consent by the parents. Sometimes, if the parents are not fully functional and contributing to the wholeness of the patient, of the adolescent, they can do more harm than good. And sometimes, therefore, we have to consider, is this a situation where we have to make certain provisions for waivers from consent by a parent and shift even to more consent by adolescent? Nearly always, though, it should be consent by the parents. As a waiver of parental consent comes in when we're determination of the consent capacity, identification of alternative adult guidance, deference to legal standards on mature minors, because sometimes, well, in other areas you have heard them being called liberated minors and so forth, and there might even be laws that allow for them to actually take care of themselves when it comes to the final decision making. The other C is confidentiality, and in the light of confidentiality related risks, make sure that that is always upheld. Compensation is the third C, and that really only comes in when we're talking about research, when we're doing research in the area. And that's the only time sometimes we usually give a compensation, an incentive, and we should be very wise about it and guided by those who are familiar with how to give incentives and make sure that it is well managed and not abused. Next slide. So, in the informed consent process, autonomy must be respected. Consider a person's capacity, simplify the language. Parents consent and the child gives assent is the usual thing. And the types that we know of are implied, verbal, and written. In situations like these, we should always try to gravitate towards written consent. Moving right along. And for confidentiality, it's, as I said, a tricky situation. Always understand the laws of the country, or if you're in like the United States, the laws of that state or of the province in Canada or whatever it is, because they differ, one state side beside another state, one country in the Caribbean beside another country. They have slight nuances in their differences. What we should be willing to do in order to ensure and encourage confidentiality as we deal with our clients is to explain the components to both the parents and to the adolescent, what confidentiality is and where it has its limits. Confidentiality is an old concept found even in the Hippocratic Oath, but it has its limits, and there are legal provisions where certain parts of that rights can be removed for the good of larger considerations of good. Appreciate allowable areas where it can be breached, and therefore you are always to do what is the wisest in this right situation. But you know, the adolescent is really the one who is in the most trouble and really should be given the most attention as we work through the confidentiality issue. That's the one needing the most protection. Next slide. Patients have rights, children have rights, and children's written consent supersedes that of parents when referring the child to the outside agencies. So even if the parent says go and the patient says no, that great consideration should be given to respecting that. Because you respect it, however, your job is not finished. Because somebody says no, it does not mean that your job is now to move on to the next person. Your job now becomes one of persuading that person, not coercing, but doing other things to enlighten the person so that they might, if it's reasonable and if you have presented a case, now alter their decision and maybe be more cooperative. In all of these things, while we're looking at these things, we should spend time to evaluate what kind of parent-child relationship is it that we have dealing with with that particular case. And here it is again, where a casuistic approach really makes more sense than a principles-based approach. Next slide. We have a duty to report as professionals who are really given that kind of responsibility, that kind of trust. And we also have a duty to appreciate when there are breaches in confidentiality as provided by different countries, that we can exploit that and we can use that. But it should always be in love. It should always be because we are trying to redeem a wholesome relationship. There should be nothing punitive about it. Next slide. The issue of danger to others really takes us now also into a public health perspective on ethics, where it makes it more tricky, because once it is a danger to others, then the interest of the community usually supersedes the interest of the individual. And you saw that many times during the COVID pandemic. You see that with other pandemics, and you will see that with other natural and other disasters as well. But throughout, we should honor the trusting relationships that all concerned need to be, in that case, really communicating with the community and giving feedback, going through our decision-making at headquarters, and also never neglecting the client in front of us, because all of these need to be weighed delicately. We indeed are gods. We are judges that have to handle these delicate situations. Never should we think of ourselves, though, as omnipotent. Next slide. I want to say thank you as I leave you with those and providential blessings as we're absent one from the other.
Thank you so much, Dr. Frankson, for a really comprehensive presentation in which you really presented the heart of the topic, which was ethics of managing substance use disorders in adolescents, balancing autonomy and mandatory reporting. Really, it's a balance. And thank you for introducing, to me at least, two new terms, principalism and casuistry. I hope I got that right, and your explanation was very helpful. All right, Dr. Frankson, you went over time, so we're really limited. Are there any questions? Because you were so thorough.
There is a question here. Which agency exactly are we reporting to? Is it the Office of the Children's Registry?
Those things need to be properly defined in Jamaica. But the Office of the Children's Registry is quite capable of those agencies. When you look at their manuals and so forth, they really are about things like sexual abuse, violence, and so on. But they do have a clause that says, and any other thing that is damaging to the child. So that is the clause that you can use and write it there if it is a situation that really needs it. And please use prudence when you're doing that. Remember, it's not every case. You have to see whether in doing so it will bring harm or more harm than good, etc. And when you interface with that agency, they will be more than able to tell you when other drug abuse related agencies now are in place in Jamaica. If you have places like Europe, Canada, United States, yes, the Office of the Children's Advocates, absolutely, Tanya. Those are the places that we are thinking of. And when you are reporting those things, also think of helping that child to be referred for the best help available. And not just the child, but the parents, and sometimes even the community.
Thank you so much, very much so. And be prepared to answer the questions you put, the who, what, where, when you do so. They have a number 211, but it doesn't often work. You may have to call the head office on Duke Street. All
Also, the
right.
Caribbean countries don't have their act together on this yet. So this is one of the great challenges for the future. So this topic is a very timely one. Maybe we in the general practitioners can advocate for that along with the psychiatrists.
Yes, we have to. So, speaking of psychiatrists, we have to move right along. We have Dr. Janique Baldwin Miller, who is ready to present. And Dr. Franklin presented on the ethics of managing substance use disorders in adolescents. Now, Dr. Miller will be looking at the intersection of mental health and substance use disorders in adolescents. As I said before, she is a psychiatrist trained at the University of the West Indies and presently employed by the Southern Regional Health Authority in the parish of St. Elizabeth. I don't know if she's presenting from St. Elizabeth, but she can let us know. She has a vibrant private practice also in Black River. She is preceptor for the All-America Institute of Medical Sciences as well. And she's passionate. She has 2 energetic, curious preschoolers. So if they come in our screen, we'll just smile and tell her to hug them. And we need to get her going because I'm sure they're tugging at her hem just now. So Dr. Miller, thank you, Dr. Baldwin Miller, thank you so much for agreeing to present. Please go ahead.
Thanks for having me presenting at this conference. I really appreciate the invitation. Yes, I'm actually presenting from Mandeville, but I work mostly in St. Elizabeth and I locked the door, so hopefully you don't hear any banging from my lovely boys. So I'm going to start to share the screen. Start sharing the screen. But you can see my screen?
Yes, I'm seeing the screen.
Okay. All right, so let me start my PowerPoint. All right, so I'll be looking at the intersection of mental health and substance use disorders in adolescents. Thank you for presenters that prepared their presentations prior, because they kind of fill in the gap with a lot of things that I'd like to talk about. So we're going to be looking at the general introduction of substance use disorders and mental health and mental illnesses, substance-related disorders, criteria for substance use disorders, the Jamaica drug prevalence statistics, the diastasis stress model for substance use disorders. Let's look at the comorbidity between substance use and mental illness and other mental illnesses. We're going to be looking at the management and some resources going forward. So substance use is a public health concern and a public security threat among Jamaican youth. And this was said by the National Council on Drug Abuse in the last couple of months. The most common substances used by adolescents are tobacco, alcohol, and marijuana. Now, psychoactive substances act on the nervous system, causing alteration in the functions that relate to thoughts, emotions, and behavior. And we're going to be looking at the specific substances during this presentation. We look at the specific issues that these substances cause. Now, the Diagnostic Statistical Manual looks at several substance-related disorders. Some include substance intoxication, which is a reversible substance-specific syndrome. So if you're, for example, intoxicated with the marijuana, you might start having hallucinations. For alcohol, you might become very anxious or disoriented, very dizzy. You might have some syncopal episodes when you're intoxicated. For substance withdrawal, a substance-specific syndrome caused by the cessation of or reduction in prolonged substance use. So some persons might think that you might have withdrawal symptoms from a substance only when you stop using it. But if there is a significant reduction in that substance use, then you might have withdrawal symptoms. And there's substance-induced disorders, such as substance-induced depression, OCD, bipolar-related disorders, psychotic disorders are a major issue caused by various substance uses. And then substance use disorders, where we're going to be looking more at in details. Now, substance use disorder is a maladaptive pattern of substance use leading to clinically significant impairment or distress. And you have to have 2 or more symptoms that persist for 12 months or more for you to have a substance use disorder. So just by using a substance doesn't mean that you're going to develop a substance use disorder. A substance use disorder might more commonly be referred to as an addiction. We don't usually use that term in the diagnostic statistical manner. That's the DSM-5. So the criteria for substance use disorder are a lot. And as I said before, you have to have at least 2 of these symptoms. And the first one is tolerance. So tolerance is needing more of the substance to get the desired effects, right? And then you have withdrawal, where once you cut down or stop with substance use, then you're having specific withdrawal symptoms associated with that specific drug. So, for example, for alcohol, you might have tremors, have insomnia, irritability, because you're cutting down or stopping that drug use. Then there's hazardous use. This includes, and not limited to, drinking and driving, or drinking or using a substance while operating a heavy equipment, smoking in bed that could, if you fall asleep and have a fire, cause hazardous use. And then there are social interpersonal problems related to use. So this could involve domestic violence because of use, or interpersonal conflicts just because you're using this substance. Then there's neglect of major roles to use. So you're not going to work, you're refusing to go to school. And here we're talking about adolescents, and more so going to school is an issue because of their substance use. They also use larger amounts, longer. There's repeated attempts to quit or control use. There's much time spent using. There's physical, psychological problems related to use. So this may include persons continuing use even though their doctor says, I would encourage you to stop because it's causing severe gastritis, or it's worsening your depression, and the person continues to use despite that warning and the ill effect it has on their health. And then activities given up to use. So you're not going to the gym anymore, you're not hanging out with your children anymore, you're not playing and enjoying things that you usually enjoy, because your time is no more consumed in obtaining the substance, using the substance, or because of the conflict between family or co-workers, you're now giving them up because of your substance use. Now, there's not much statistics as available for substance use in Jamaica for adolescents, but the National Council on Drug Abuse shared this slide with me, and I just want to acknowledge them for that, and then jump to the statistics. So for adolescents, we can see here that the average age of onset for first use for males is 16, and for females it's 18. And the most common drug that is used is alcohol, which is 46% of the group that was assessed, and the group was about 4,991 participants. And then cannabis was the next at 17.1%, and cigarettes was 11.8%. And this is over the last 30 days. Now, the diocese stress model for substance use disorder says that certain people, due to the variety of biological-based factors such as genetics, neurocognitive functioning, or stress response, may be predisposed, which is diathesis, to developing a substance use disorder. They could go through their entire lives never developing any kind of addiction. On the other hand, if the right stressor or combination of stressors are present, then the person might develop a substance use disorder. And this diathesis stress model for substance use is also present for other psychiatric disorders. So what we're saying is that for persons to develop a substance use disorder or any other type of mental illness, there has to be some biological predisposition or the diathesis, and then there's a stressor that causes persons to now develop the substance use disorder. So going to etiology, we spoke earlier about genetics. And why we say genetics? Because several twin studies indicate that persons, monozygotic twins, have a greater concordance of developing substance use disorder if one twin develops it, compared to the dizygotic twins. And then for adoption studies, persons who live outside of their homes and they had parents who had a substance use disorder are more likely to develop a substance use disorder even though they're not in that household. So we're thinking that there was some genetic predisposition that had caused these persons to develop this disorder. And then there's the psychosocial factors. I'm going to be looking more into that. So the psychosocial risk factors for substance use for adolescents include parent modeling of substance use. So once they have a parent using a substance, marijuana, alcohol, cigarettes in the home, or any other caregiver using it in the home, it increases the risk of the adolescent using this drug. Also, parent believes in the harmlessness of a substance can be passed on to their kids, and they are more likely to take up the habit. Children who live in a family with high conflict also are increased risk. If there's lack of parental supervision, oftentimes when I have clients coming into my office and there's an issue with an adolescent substance use, then we have to really sit down and talk about parental supervision, supervision at home, supervision at school. If they're not at school or at home, is there a responsible person supervising them, ensuring that they're staying out of harm's way, which include using substances. This literature also talks about maternal passivity. So if mothers or other caregivers, I would want to say, is not very adamant about substance use, they're not talking to their children about substance use, it's either here nor there, then those adolescents are at more risk. Adolescents with academic difficulties, if you have peers using substances and there's significant impulsivity. Now, we know that adolescents are quite impulsive. We say that the frontal lobe is not fully developed until after about 25 years. And so the lower brain, the limbic system is in overdrive, not being controlled to a greater extent by the prefrontal cortex that says, hey, I shouldn't do this, this has this risk. There isn't that back and forth thing for adolescents. And so the impulsivity, they're curious, they want to try new things, puts them at increased risk of developing substance use. But Also, adolescents who suffer from attention deficit hyperactivity disorder are going to be at increased risk for substance use, persons with intellectual disability, also again would be at increased risk for trying these substances and developing a substance use disorder. And looking at protective factors, stable family life, strong parent-child bond, consistent parental supervision, investment in academic achievement, and peer group that models pro-social family and school behaviors are protective factors. And when we are looking more on treatment for substance use disorders, we have to try and see how we can increase these protective factors and decrease the risk factors for persons more likely to be trying a substance and become dependent on it. So the co-occurrence of more than one substance use disorder or the combination of a substance use disorder and another psychiatric disorder is quite common. So a client coming in with alcohol use disorder more likely will say that they also use cigarettes, they also use marijuana. And then when you do the history, there is a risk. You also are going to see another psychiatric disorder like depression or anxiety, they are present. So 50% of adolescents diagnosed with alcohol use disorder had an additional psychiatric disorder, especially a mood disorder. And the diagnosis of alcohol use disorder was likely to follow rather than precede other psychiatric disorder. And this is common with other substance use disorders like cannabis or nicotine use disorder, where when you do the history, patients would present and say, I was feeling depressed, or I was very anxious, or I was grieving the loss of a relative, or there was a history of sexual abuse and trauma, and then they started to use this substance. So then it leads to the question, are they self-medicating? As my colleague said earlier, persons would say have good mental health or is mentally well when they're calm, they're relaxed, they feel good about themselves, they are able to function well and thrive. And everybody inadvertently wants this. And because there's such a stigma associated with mental illness, persons are not going to step forward and say, hey, I'm suffering from anxiety, I'm suffering from depression, I have constant flashbacks from sexual abuse that have happened to me in the past. Then instead of coming forward and getting the help, some person say, you know what, let me try this substance. Let me see if this can help so I can feel better. And they do feel better in the short term, but in the long term, it doesn't treat the underlying illness. And then there's this risk of developing substance use disorder. So comorbidity influences treatment outcome. It is important to pay attention to other disorders such as mood disorders, anxiety disorders, conduct disorder, or ADHD during the management of substance use disorders. So how do we make a diagnosis? We do take a history. Take a history. I'm talking to the patient and a reliable source. We make our observations. So this is the mental status examination, looking at their general appearance, their behavior, and if they're acutely intoxicated, etc. And then we do laboratory tests, we do blood tests to see if there's any other drug on board. So some persons may admit to, say, alcohol use, but when you take the blood test, then we find there's cannabis there, and sometimes shockingly, there is cocaine there. So I'm going to be looking at some of the effects of these substances that our youth are commonly using. So first of all, we're going to look at marijuana. So marijuana has some short-term effects. There's impairment in memory and learning. There's distorted perception, diminished problem-solving abilities, loss of coordination, increased heart rate. There's anxiety and panic attacks. And sometimes when persons use this for the first time and they have these adverse effects, it's a deterrent for further use. But persons sometimes persist and continue using, and there's an increased risk of developing a psychiatric disorder. So a study done indicated that persons who start substance use in adolescence are increased risk of developing a psychotic disorder like schizophrenia in early adulthood. There's also deficits in verbal learning, memory, and attention. And we know that there's different ways adolescents can consume these drugs. So they don't have to be sitting in front of you smoking for you to say, oh, wow, you're smoking. Let me get help, or let me intervene and let me assist you. There are edibles, brownies, gummy bears that persons can be using. And these, in whatever form, has a significant effect on their physical health and mental health. Then club drugs, and looking specifically at Molly, this has increased availability for adolescents, especially those who frequent clubs, raves, bars, music clubs, and can be added to drinks without detection because they are often colorless, tasteless, and odorless, or they're in a very cute little form like a heart or some colorful pills, and children might think that, you know, this is probably harmless because of the form it is, and they will use. And because of the effects of this drug, persons might be at risk of sexual abuse. And so it's commonly reported as a date rape drug. So persons who consume Molly may have dry mouth, increased heart rate, fatigue, muscle spasm, or hypothermia. And they sometimes will present to the accident and emergency department because of these symptoms, and might need care because of that. And again, we see in the media how there's concerns about the drug Molly being glorified in or popular music, and so persons are further encouraged through these media forms to use the drug, and there's no emphasis on the adverse effects of the drug. And again, nicotine, when I was in residency, I remember Barney, who was our addiction treatment specialist. He would mention that nicotine is one of the most addictive substances known. And it is so easy to start, but so difficult to stop that use. Young teens who smoke cigarettes or vape are also exposed to other drugs and more frequently than non-smoking peers. So nicotine, along with marijuana and alcohol, are thought to be gateway drugs. So you start using it, you're going to be in the crowd of persons that are using this and other drugs, and then there's an increased risk of you being a polysubstance use, having polysubstance use. And in alcohol, adolescents are not at increased risk of developing some of the more severe cognitive deficits associated with substance use that adults might experience. But again, we know that it can affect their cognition. So children, for example, who are depressed or very anxious might think that alcohol may be the way to assist them in just calming down and relax and going through social interactions or managing school or family situations. But in the long run, it impacts their memory, their functioning in school, and puts them, it's almost like it just worsens the underlying psychiatric disorder that they wanted to manage, quote unquote, in the first place. And then we know, again, a teenager doesn't have to have a shot glass in front of you using rum or a cup of rum and Red Bull. They can just have one of these rummy beers. These are gummy bears that are soaked in rum overnight and then frozen, and you think they're just stacking on some candy, but they're actually using a drug. So treatment. First of all, we would want to prevent any adolescent from having to suffer from a substance use disorder. We, in mental health, consider substance use disorder a chronic illness. So there's increased risk for relapse at numerous times in their lifetime. And so we would want them to avoid using these substances. You don't know if you have the gene. You don't know if you're genetically predisposed to developing this disorder. So I would say to a team, why start in the first place? So for screening, there's a structured and unstructured interview held to determine the type of substance being used and the quantities and frequency. We use motivational interview, which helps persons to consider stopping their use and looking at the benefits and the disadvantages of using substance and use that as a motivation to help them to maintain sobriety. There's also use of cognitive behavioral therapy, family therapy, group therapy, using pharmacological intervention. So as I mentioned before about the comorbidities, oftentimes when you're treating the underlying psychiatric disorders like depression, anxiety, or PTSD, or ADHD, then persons are at greater are more able to stop your substance use when those underlying psychiatric disorders are managed. And then we have to determine the treatment setting. Some persons will do fine on outpatient treatment setting, especially when we have the buy-in from caregivers, from parents, in ensuring that these children are properly monitored. Sometimes we have to use a day hospital approach. Some group homes do facilitate treatment of substance use disorders, and then there is a possibility for having inpatient treatment. So this is one of my last slides, and I just want to share with you some resources that are available for youth who are struggling with a substance use disorder. First step is usually the school guidance counselor, and if they're not able to manage the substance use issues, then there's a National Council of Drug Abuse available. The Jamaica Early Warning System on Drugs is a committee that helps us to be aware of what are the trends and how to look out for some of the warning signs in our homes and in our schools. And a very important resource for us to be aware of and to check in with them. Then there's a guidance on child and adolescent guidance clinic, which are available in all parishes in Jamaica, and is manned by a psychiatrist, psychologist, and social worker. And this team helps adolescents to cope with their substance use issues and maintain sobriety. Then there's Teen Challenge in Jamaica, which is almost a group home that assists patients in managing their substance use disorder, and this is more of a long-term treatment facility. We know that persons who have moderate to severe substance use disorder benefit from not just short-term treatment plans, but long-term treatment plans, and Teen Challenge offers that. And then there's AA, and we do have it in Jamaica. They have chapters in Kingston, Otorias, and Negril, and thankfully, there's also online AA that persons in Jamaica can join if Kingston, Otorias, or Negril is not available for you, and you can seek those resources for yourself and for your clients. So thank you very much for listening, and I hope that was helpful.
It was indeed helpful, Dr. Miller. And thank you for those aids. Again, I would like you to put them in the chat because I don't think we could write it down fast enough. And those are so useful in terms of seeking help for teens who are on drugs. Very comprehensive substance use disorder. So we don't use the term addiction, but it's the same thing.
Yeah.
All right. And also giving us an idea what to look out for, both short term and long term. On the issue of self-medication, I thank you for highlighting that particular aspect. I remember having a patient who had ADHD, and he was convinced that marijuana helped him to be calm and to be less impetuous. And we had several discussions on him trying to seek help and replacing the marijuana for his treatment. Any suggestions that other than, I can't remember what happened, sent him to psychiatrist. I don't think he went, but any suggestions there for, in particular, persons with ADHD?
Well, when a client comes to you with a substance use disorder, they are trying to cope. So I think as clinicians, you have to approach it with empathy and say, you know, I know you're having this struggle, ADHD, depression, anxiety, and you're using this substance. I know it helps you, but I'm concerned about the health, you know, the physical health and the mental health. It might make things worse. I have this alternative. I think this could work. Let us try and see how we can partner. And if it doesn't work, we can try something else. But I'm definitely concerned about using the substance, and I want it to be healthy. Let us work together to ensure that you have good mental health. And I think if we approach them in an empathetic and not a judgmental way, you know, by using substance, you know, this is not good for you, and you know, what are you? Are you, you know, a druggie, or you know, start naming them and shaming them? I think they need our, you know, empathy or love or guidance. Also, persons are not aware that, you know, I'm doing this because of this. So if you can show them and just tell them this might be the better way, let us try it. Then you might have a buy-in. And then, as I said before, substance use disorder is a chronic illness. So, you know, there's going to be a struggle in cutting down, quitting, and staying sober of these drugs.
Thank you very much also for highlighting motivation interviewing in terms of our screening and for continued care in trying to get change and of course in maintenance of change. So our work in motivational interviewing is very important. Thank you for highlighting that. Sam, are there any questions in the Q&A?
Sorry, I was muted. Yes, number of questions here. First one I see is, how does passive smoking affect mental health?
How does, sorry?
Passive smoking affect
Passive
mental health.
Passive smoking. So this is secondhand smoking the person is mentioning?
I'm not sure. When I see it, I kind of think of somebody that maybe doesn't. I don't know if it's a casual smoker. Maybe it's secondhand.
Okay, well, I'm going to answer based on secondhand. So persons can become intoxicated with secondhand smoking. You can, for example, secondhand smoking marijuana, you can get a high, you can start having hallucinations based on how much you have ingested. Especially if you're not smoking, you're at increased risk of having some kind of intoxication, and that can affect your mental health.
Thank you so much. I see a question here. What is AA?
AA is Alcohol Anonymous. So this is a faith-based treatment plan that helps persons who are struggling with alcohol, but other substances to get that support in staying sober. And we know in mental health that persons do much better when they have that support system and a strong support system. So if family is not available, church not available, community members not available, then you can find help through AA groups. So.
Thank you so much. Excellent presentation, Dr. Baldwin Miller. Can you say more about the Jamaica early warning system on drugs?
Yes, so this is a committee that was formed recently that it was done because of the substance use issues that we've been seeing in our schools and in our youth. And so they wanted to just have a committee that meets, I think it's once a month, that looks at the trends so that they can warn schools, parents about what these trends are and how to protect our children, safeguard our children. And to
Perfect. Go ahead. Sorry, you were finishing.
And to make policies to help to protect them.
Thank you. What pharmacological treatments are available for a Molly addict that can be prescribed as maybe a trial therapy or an initial therapy?
We don't really have any pharmaceutical drugs available for treating Molly. The most common thing that we do is motivational interview. But again, if this person is suffering from any other psychiatric disorder like anxiety disorder or depression or PTSD, then we could use an antidepressant, and that can help to cope with that underlying psychiatric disorder, and then they're better likely to stop their substance use.
Thank you very much. Oh, go ahead, sir. Go ahead,
But for
sir.
nicotine, for nicotine use disorder, we have the patches available in Jamaica. We have gums available. We have pharmaceuticals like Wellbutrin, which is a drug that helps persons to maintain sobriety, along with the gum and the patch. And it's an antidepressant, but it can be used for persons with substance use disorder who do not have depression.
Thank you very much. I see a question here from Grace Hall. It says marijuana use and abuse is so widespread in Jamaica. How do we address this issue? So many persons do not see it as a problem.
Yes, so it's almost ingrained in our culture. A lot of our youth are exposed to it, are used to it. But we have to try and see how best we can educate our youth to help them to understand the the effects of this drug. So a lot of a person just think it's just innocent, that it's just helping me to relax, and they don't understand that they can truly develop a mental illness, anxiety disorder, depression, psychosis. And I think once we educate them, it can go a long way. And then adolescents are adolescents, they are still children, and us as adults have to be that protective factor. We have to protect them, we have to keep them safe. I mean, there's a lot of times I go out and I see an adult allowing a child in uniforms to sip a rum and Red Bull, right? And I think that is okay. And as a professional, I'm passing and I'm not going to keep it. I'm like, you can't do that. You can't give the youth, rum. I was at a restaurant and I saw an adult have a beer and giving it to a child in hand getting breast milk, and I'm like, why are you introducing? It's just beyond me. I think in our culture we are just very, laissez-faire about substance use, and we think it's quite fine to introduce it to our youth, but we have to, as a culture, say, no, we have to protect our youth. We have to protect our youth from substance use. And it starts with us as adults. We have to make that effort.
Thank you very much, Dr. Miller. We're going to have to press on now, but that last statement is timely. And remember the village. Sometimes the adults just don't think, so we have to prompt them. And as you said before, that education is very important, not just for the adolescent, but for the parents and the guardians. So thank you so much, Dr. Baldwin Miller. We're going to press on, and we've really had a fantastic first half of our webinar. And so we're going to take a little change, move away from substance abuse a little bit, and look at body image and self-esteem in adolescents. So we're going to have a very interesting speaker. I've heard her so many times, and she's always excellent. And she is Abigail Harrison, who is a senior lecturer and a pediatrician and head of the Department of Child and Adolescent Health at the University of the West Indies, and head of the Department of Child Health. And mentioned before, she's consultant, pediatrician, adolescent medicine subspecialist. Abigail, when did you grow up? I always thought you were an adolescent yourself.
I'm trying to hold on to that.
All right. So her expertise is adolescent medicine, and her research interests include delivery of healthcare services to adolescents, adolescent resilience, disordered eating behaviors in adolescents, and transition of care for adolescents. And we look forward to your presentation now.
Thank you so much, Dr. Williams-Green, and thank you to the organizers for facilitating me presenting today. Good afternoon, everybody. So this has been an interesting journey preparing for this talk because, to sort of just organize everything and have it ready to allow it to make sense to the audience. I hope I'll be able to achieve that, but we're going to be looking at body image and self-esteem in adolescents and how we navigate the reproductive health issues. So first, we'll give a little bit of definitions just so we can set the context for everybody, epidemiology as well, so that you know what you're looking at. And then we'll go through the reproductive health issues that we may see in 3 specific cases. So anorexia nervosa, obesity, and polycystic ovarian syndrome. And then finally, we'll wrap up with discussing an approach when you have an at-risk adolescent in your practice. So our first case, first of 2, is a 13-year-old who presents with weight loss over the past 6 to 12 months. Her mom reports that she has always been on the chubby side, and she decided that in preparation for high school, she would lose weight. This was going very well. She lost an initial 15 pounds and got a lot of compliments from everyone, family and friends included. She continued to exercise, but now she would refuse dinner if she hadn't gone jogging that day. And Mom noticed that her lunch container started to come home untouched. Now, over the past month prior to her presenting to me, she was noted to be a little bit more irritable than usual. She was spending far more time in her room, and she preferred to eat in her bedroom. Her 16-year-old sister, who was also a patient of mine, was who actually became the most concerned and pressured her mom, insisting that she carry her in for review. So just to give you a little background, she had started having her periods at age 11, and her cycles had been normal up until the last 6 months when they became a lot lighter. And in fact, her last menstrual period was 2 months prior. If we look at her curve, you will notice that she had always been on the 95th centile, between the 90th and the 95th. And then if we followed her up to when she started, which was about 6 months before, she would have taken a significant nosedive, perhaps about 40 pounds in total. So if you had not known this young person before and didn't have the advantage of her previous weights, you would have plotted her and thought that, well, she was fine. So let's go through a few definitions. So what's self-esteem? This refers to the concepts and the feelings that you have of yourself, your belief in your own worth. So it's tantamount to self-regard, self-estimation, self-worth. And there are many determinants, but some of the big factors include approval and support, particularly from parents and family, and of course from peers. What the research shows is that low maternal acceptance is one of the factors that plays a huge role in the development of low self-esteem, in addition to a maternal history of depression. Now, of course, exposure to negative interpersonal feedback and content, particularly through social media, which one could consider the super peer, because that peer is always with you at all times. It's like an extension of you. And this is particularly concerning because there are many social media sites that have a lot of weight-conscious feeds that are going on. Self-esteem is recognized as a significant contributor to health outcomes and quality of life. Self-esteem challenges often become apparent in the period of adolescence. Now, developmentally, we remember adolescents want to be like their friends, their peers. They want to be accepted, and they're far more sensitive to criticism, whether this is real or perceived. They experience significant change in their body type. Girls get far less lean mass. They have increased adiposity. They're developing breasts. They're having wider hips, and males have an increased drive for muscularity. Lots of change is happening. Low self-esteem, when it occurs, now increases that susceptibility to criticism, and it may increase their pressure felt to achieve this ideal body type. Now, self-esteem is very closely related to body image. Body image is a person's perceptions, thoughts, and feelings about their body, the perception of their overall physical appearance, their satisfaction with an evaluation of their body. And body dissatisfaction is a significant component of body image, whether it be satisfaction or dissatisfaction. And this can lead to major health concerns, which for the purpose of this presentation, we're going to lean on disordered eating behaviors and attitudes. So what are those? So those are a wide range of unwarranted weight control measures in someone who has an altered perception of their weight. So it may include severe caloric restriction. It may include abnormal eating patterns, whether it be skipping meals or consumption of unusually large quantities of food, which we refer to as binges. And then there comes compensatory behaviors such as excessive exercise, use of laxatives, diet pills, or complementary alternative medicine, as well as self-induced vomiting. Now, disordered eating behaviors usually initiate in adolescence. And unfortunately, if not managed appropriately, most adolescents will carry their disordered eating behaviors into young adulthood and even beyond. For the purposes of today, I'm going to really lean on 3 of the main eating disorders that we have, and that's anorexia nervosa, bulimia nervosa, and binge eating disorder. I'm not going to spend a lot of time on the diagnostic criteria because I don't think we need to go there, but suffice to say that anorexia nervosa essentially is a restrictive eating disorder that eventually leads to worrisome and dangerously low body weight. There's an intense fear of gaining weight, and there's a disturbance in how they view their body. There are 2 types, restrictive and binge purge subtype. But also, trickily, there is something called atypical anorexia nervosa, where you'll have all of these symptoms, but your low weight doesn't exist. You may have normal weight, but you would have had significant fall in your weight, or you may have just failed to gain weight appropriately. Because remember, they're adolescents, they're still supposed to be growing. Bulimia nervosa refers to the situation where you have recurrent episodes of binge eating, and that's really just eating a large amount of food in a discrete period of time with a lack of control. And that discrete period of time is typically considered 2 hours. This is then followed by significant shame and guilt, and then there's compensatory behaviors to avoid weight gain. Self-evaluation for these persons is unduly influenced by body weight. Now, finally, binge eating disorder refers to recurrent episodes of binge eating, but without the purging. And this is probably the most common, not probably, is the most common of the 3. So similarly, it will be rapid eating until uncomfortably full, this difficulty stopping, and there's guilt and oftentimes discussed after you've overeaten, but no compensatory behaviors. Now, persons tend to think we don't have these problems here in Jamaica. I think that's shifting a little bit now, thankfully, so that we will be more aware. So some years ago, as long as 10 years ago, wow, I didn't even realize that. Myself and Prof. James, at the time she was Dr. James, we went out and we looked at our high school participants in Kingston, St. Catherine, Clarendon, and obviously St. Andrew. We looked at 521 young people with 292 girls, and as much as 1 in 5 of our young people, almost 1 in 4, were identified using the Eat26 screen as being at risk for developing an eating disorder. Yes, females were more, it was a higher prevalence than in the males, but look at that, we had 16% of our males at risk. Concerningly, 31% of our young people were engaging in at least 1 disordered eating behavior, with binge eating being the most common. We had as much as 8% engaging in self-induced vomiting and 3% using chemical methods. Now, if we look a little bit more closely at actually diagnosed eating disorders, we looked at this in the last almost 13-year period. And what we found was that we had in both a combination of public and private practice, and we also reached out to our other colleagues, other psychologists, and as well as psychiatrists for eating disorder patients that they had managed. And we had 62 persons between the age 10 and 29. Now, what you will notice is that 1/3 of them presented in early adolescence, so that's 10 to 14, when they were diagnosed. But what's even more concerning is that we took almost 2.5 years for them to go from onset of symptoms to a formal diagnosis, because people didn't realize what was going on. Parents didn't realize, physicians that they went to prior to coming to us didn't realize, and so the boat was missed essentially. I don't need to talk to you about obesity, but I will share the concern that we are having rising rates in overweight and obesity. If we look at the 2010 compared to the 2017 Global School Health Survey data, we'll see that, it's significantly increased, almost a doubling for our boys, and significantly maybe about 30% increase for our girls. So Obviously, since we're looking at reproductive health concerns, we're going to be focusing on girls. Now, our first case was diagnosed with anorexia nervosa. What does that have to do with reproductive health? Now, in anorexia nervosa, there is generally hormonal dysregulation. There's suppression of our HPG axis, and there's the reduced production of estrogen and progesterone. So essentially, you have hypogonadotropic hypogonadism. Now, what we need to remember is that sometimes we'll have oligomenorrhea, sometimes we'll have normal periods, and sometimes we'll have amenorrhea. Usually that's when it's far gone. So we want to recognize them before they're at the amenorrheic phase, and we have removed that, as you will notice, from the diagnostic criteria. It is no longer there. You do not need to have amenorrhea to be diagnosed with anorexia nervosa. And remember that little tricky group, which has the atypical anorexia nervosa patients who may have perfectly normal weight and therefore very normal periods. Now, one of the other concerns with anorexia nervosa is that because of chronic anovulation, if you are amenorrheic for a long time, you are at increased risk of infertility long term. If it starts early, you may also be at delayed onset of puberty. And we have had a few patients who have presented to us as young as age 10. We have a new patient who is now age 8 presenting. And so we have to be very aware of this so that we can monitor and look out for these as causes of delayed onset of menses. There may be stunted growth, and long-term, there is an increased risk of osteoporosis. Certainly, there are pregnancy risks. I mean, we don't want our adolescents getting pregnant, but some of our young adults may be willing and able to manage a pregnancy. But one of the things that happen is that with this distorted body image, many of them do not engage in any sort of partnership. And in fact, I often am very happy when they do end up with a partner, because I'm like, yay, that means the body image is coming back, because they're now more comfortable with themselves. They can now engage in a healthy relationship. But it can certainly have an impact on their fertility and their experienced sexuality. There's also oftentimes, especially with our restrictive eaters, a fear of pregnancy because of the potential weight gain. Right? So the thought of their bodies changing so much, they cannot manage that, and so they avoid it. There's also stigma in terms of reluctance to seek care because they are either uncomfortable with how overweight they are, or, well, in anorexia, not so much, but concerned with how people are going to view them because of how underweight they are. They recognize that other people are telling them they're underweight, even though they don't actually believe it. But they know if they go to the doctor, there is a potential for a judgmental sort of response, and they don't want that. There's also the risk of spontaneous abortion for those who are able to get pregnant, as well as premature delivery and low birth weight at that time. Now, we move from anorexia nervosa with low weight to adolescents with obesity. Now, adolescents with obesity are more likely to experience oligomenorrhea. They're more likely to have heavy or irregular menstrual bleeding due to anovulatory cycles. And they're also more likely to have dysmenorrhea because of the impact of increased inflammatory markers, which goes hand in hand with obesity. They also, because of impaired ovulation, may also be at increased risk for endometrial cancer because of the unopposed estrogen from this chronic anovulation. There's again increased risk of subfertility or infertility later on in life. And on the flip side, there's an increased risk of macrosomia, an increased risk of gestational diabetes, preeclampsia, as well as a C-section delivery. Now, the psychological and social impact is significant. There is marked body image dissatisfaction typically. There is oftentimes low self-esteem, and unfortunately, in this vicious cycle, they may then be led to high-risk sexual behaviors or avoidance of any reproductive health care. Remember, we spoke about the stigma and the worry about judgment when they're seen by healthcare providers. and they may even have difficulty with partners. I remember very clearly a young woman, she was about 19, with marked obesity, and she was just so happy that her partner, her boyfriend, was willing to explore different sexual positions because of her obesity. And she was very appreciative of that. And, you know, it struck me because it wasn't something that I had actively thought of when I was initially interviewing her to ask her if she had had that difficulty. They're also recognized as having increased rates of depression, anxiety, and eating disorders. So our second case is a 16-year-old girl, again referred with obesity, as a result of difficulty achieving any weight loss. This was her physician that had referred her. She had given us a little bit of difficulty for me to really develop adequate rapport to get the required history. But she had disordered eating behaviors and attitudes for at least 1 year prior, with restrictive eating patterns when I was seeing her. She had a history of a very difficult relationship with her mom, who was particularly critical about her weight. She had marked depressive and anxious symptoms, and on examination, her weight and body mass index were significantly above the 95th percentile. There were no other concerns at that time on examination. She was assessed as having major depressive disorder, social anxiety disorder, and disordered eating behaviors and attitudes. She had not at that time met the criteria for an actual eating disorder to be diagnosed. I started her on an SSRI for her depression and anxiety and referred her very promptly to Dr. James right here on this call, who is our only ED, eating disorder psychologist in the island. She progressed over the next 6 months with continued weight gain. She was then noticed to have acanthosis nigricans, and in view of that, we did a full workup and everything came back with no significance. But we recognize that this is not uncommon in the adolescent phase. So we continued our efforts at dietary management. She was very haphazard with visiting the dietitian. We have no actual eating disorder trained dietitians locally. And so sometimes we can have a little bit of difficulty because sometimes the rapport that is built and the approach that's taken is not always ideal. And so there was low adherence with those visits. In addition to which, the dietitian is usually telling the patient what they don't want to hear. So she continued in psychotherapy, and then, as is very common, her restrictive eating, which is very hard to maintain, was switched over to binging and purging. She was then diagnosed, in addition to her depression and anxiety, with bulimia nervosa. At a year, with continued weight gain, in spite of her blood work still being normal, we decided to give her a trial of metformin. Well, not surprisingly, there was poor adherence due to side effects. So that was a bust. We did try, but she wasn't taking us on. Currently, and this is now maybe about 5 years later, she's overseas, and so we have intermittent contact. Her obesity persists, her depression persists, but now the focus of it is a little different. It's now on, you know, having finished school, what next? Her anxiety is much improved, and she has thankfully better coping skills because she has persisted at least with one arm of management, which is the psychotherapy. She still has significant body dissatisfaction and continues to say she plans to start exercising. But one of the big barriers for her is the embarrassment and the shame about going out in public at her size. Now, you would have probably figured that we were alluding to the fact that she may have polycystic ovarian syndrome, which is a multisystem disorder with reproductive, metabolic, and psychological manifestations, and it can affect up to 13% of women of reproductive age. I'm very certain that you all know the diagnostic criteria, but suffice to say, these do not always match up in the adolescent female. So you just have to have a high index of suspicion. Now, women with PCOS are more likely to have an eating disorder as much as 3 to 6 times increase. That's amazing. And this is particularly with binge eating disorder, but also with bulimia nervosa. No real relationship seen or correlation seen with anorexia nervosa or avoidant restrictive food intake disorder, which is the other eating disorder on the rise. We know that they have increased body dissatisfaction and perception of being overweight, even though some of them are not overweight. And they usually have multiple attempts at weight loss that are not successful. As you noticed with case 2, the restrictive eating patterns that they tend to start out with often migrate to binge eating, whether as BED or BN development. And many of them will experience menstrual irregularities. Of course, the hyperandrogen symptoms of the hirsutism, the overweight, and then concerns about subfertility. And all of these features tend to make a lot of these women feel less like women. And so it can significantly lead to significant emotional distress and low self-esteem. And then the vicious cycle continues because those things may lead to further binge eating as a part of emotional eating. Now, from the pathophysiology point of view, persons with PCOS have an increased sensitivity and hyperresponsiveness to ACTH, which then leads to increased production of cortisol and increased androgens. And androgens are orexigenic, which means they stimulate appetite. And they also decrease impulse control, right? So all of these things make it very hard for these persons to be successful at weight management by reducing intake. Now, insulin resistance is an added factor because when you have the hyperinsulinemia, it then causes postprandial falls in your blood sugar, which then makes you feel hungry. You then have a craving for carbohydrate-rich foods and drinks. The studies are not yet definitive on whether foods with low glycemic index are really making a difference in improving this reactive hypoglycemia, but many persons will be advised to try that. There are also other chemicals such as ghrelin, which is another like a cytokine, which helps to manage feelings of hunger. And there's an imbalance in ghrelin in persons who have PCOS, and so they have more food-seeking behaviors, and this may be along with overeating. Now, the management of PCOS is really outside of the remit of this presentation. However, we know that the two main things that are used would be either metformin, which is an insulin sensitizer, or the combined oral contraceptive pills. And both have difficulties for adolescents. Metformin has horrendous side effects. And yes, we know maybe in about 2 to 3 weeks they will wear off, but there are very few adolescents that are going to stick with it after those 2 to 3 weeks of awful nausea and abdominal discomfort, right? In addition to which, they just don't like to take medications, and the metformin is a pretty large pill. The OCPs also have their problems because they have side effects, of course. If you are already overweight or have obesity, then, you know, everyone is reluctant to go on an oral contraceptive pill. Even if you have normal weight, young women are reluctant to go on the oral contraceptive pill because of the likely weight gain, right? So essentially, although these things are helpful, so the metformin does improve your androgenic profile, and OCPs definitely will assist with reducing hirsutism, but it really has to be an individualized treatment plan for patients with PCOS where you share the decision making. So you can't come down with a heavy hand as, you know, you got to do X, Y, and Z. It has to be, okay, these are the things that we're thinking may be helpful. What do you think you can manage and start with today? So how do we approach these adolescents who are at risk of these problems? And essentially, what you want to do is very gently screen. Every patient, you really should inquire about potential body image issues, about potential disordered eating behaviors, but you want to inquire gently and be very non-judgmental in your approach. So these are some of the typical questions you could ask. Do you worry a lot about the way you look? and wish you could think about it less. So does it occupy a lot of the time in your day? And a very arbitrary assignment is more than an hour, being considered excessive. What are some of the specific concerns you may have about how you look? And how does that impact you? So, does it change the way you dress? Does it change the places you go to? Does it change the things you do? Does your weight affect the way you feel about yourself? So you'll have lots of young people that wake up in the morning, they jump on the scale. If their weight has gone up, their day is ruined. If their weight has gone down, they're like, yay, I can have an awesome day. And it really should not be like that. What do you think of your eating patterns? Are you satisfied with them? Are you having your meals on time? Are you skipping meals, etc.? And do all of these problems around eating make it hard for you to achieve what you need to achieve, whether it be work or school or hanging with your friends or with your family? There is a questionnaire, a screening questionnaire, which you can use. I don't particularly like it, but it is globally quite utilized. I don't think we need to do this because we generally have a little bit more time with our patients where we can quickly ask them these questions on our own in a more gentle way, because you want to make sure if it's a young adolescent who doesn't even know about laxatives, that you are not introducing them to that as a way to manage their weight. Or if they've never thought of self-induced vomiting, you don't want to promote that. So you could say, adjust question 1. So do you do anything to try and control your weight? So you're very general. And then when you're doing your review of systems, you can then say, is there any vomiting? Is there any diarrhea? So they don't know that what you're digging up, okay? You ask, do you ever have episodes where you feel like you're eating too much and you can't stop? And then you can go through the rest. And this is freely available. We should screen every adolescent for depression. This is the Patient Health Questionnaire 2-question screen. A score of 3 or more suggests that depression is likely. The Generalized Anxiety Disorders 2-question scale, similarly screening for anxiety. And again, if you get 3 or more, it's considered clinically significant. So what we need is a non-judgmental, weight-neutral approach. You want to focus on healthy behaviors, healthy eating patterns, not the number on the scale. We're in a stage, in a space socially where there is so much focus on that number, but it really is not the determining factor, the primary determining factor of a holistic approach to health. Diet, lifestyle, and weight management recommendations must be delivered in a sensitive manner to avoid triggering disordered eating behaviors and attitudes. Our goal that we're setting is to be able to have intuitive eating. If I feel like eating because I'm hungry, then I'm going to eat. If I'm going to eat because the food is just there, then no, that's not intuitive. I shouldn't be doing that. I shouldn't be managing my stress, utilizing eating or purging behaviors as my coping strategy. I should engage in physical activity that I enjoy, not just because it helps me to lose weight. And I should be approaching eating with a healthy attitude. There must be collaborative management, an eating disorder trained physician, ED trained dietitian, ED trained psychologist and/or psychiatrist. And I would urge you, if you have a patient who you think has significant DEBs, or you think that this person fits the criteria for an eating disorder, please refer. It's an interdisciplinary team that's most effective. For us locally, we have the options of inpatient, outpatient, or day patient. Predominantly, everything is done outpatient. We don't have residential treatment where you stay for months in Jamaica. And the goals really are to diagnose and treat rapidly, involve the family in the treatment using family-based therapy, ensure you have a therapeutic alliance not only with the young person, but very importantly with the parents. And we aim to restore not only physical, but psychological health. These are the references that I used to prepare for today, and I thank you for your attention.
Thank you so much, Dr. Harrison. Not surprised that it was such a detailed, comprehensive, but such an edutainment at the same time. And we're really grateful for that. let's see if there are any questions. I don't see any there. No.
No questions. I think the
It
presentation
was
was
so
just so
thorough.
clear.
Thank you again, Dr. Harris.
Most
Eating
welcome.
disorders, it's something that we perhaps ignore. It may be under our noses and it completely pass us by. And we depend a lot on the parents or the siblings to help bring us in. And so as family physicians, we just have to think about this. That's another item on the plate. And the other thing I'd like to say, ask you though, when a parent who's obviously obese says to you, the doctor, how can I get her to lose weight? How do you respond to such a request?
Right. So that's always a tricky experience, but generally what I recommend, similar to when a young person is diagnosed with diabetes, I usually will recommend, you know what, this needs to be a family change. So everybody's going to start exercising appropriately. Everybody's going to encourage each other to eat better timing, better balance of our foods, because we don't talk about good and bad foods, because everybody occasionally will have some inappropriate processed food, and that's okay because it tastes good, but we can't be having it every day. You know what I mean? So we want to be eating well, making sure that we have a balance of our proteins, our fats, our carbohydrates, and not completely removing any of those from the meal. But the other flip side, though, Dr. Williams Green, is that sometimes parents can make very inappropriate remarks, you know. So I remember I had a little 11-year-old just going through puberty, and she was sitting up on the bed, and her tummy sort of crumpled when she was sitting up. And her mother then said, "Oh my goodness, you're getting a little puffy there. We'll have to work on it." And I immediately had to jump in and say, no, no, no. This is a normal progression. This is how our body is going to go through, and then we will redistribute how the weight is spread, and this is normal. So you leave her alone. You let her just be very comfortable.
Thank you so much for that addition. Something wise, something to remember, and perhaps even our usual well visit to remind the parents that when they're moving from pre-puberty to puberty, what they need to expect. We need to advise the parents as
The
well.
anticipatory guidance, absolutely.
Thank you so much. Excellent presentation.
Thank you.
So we move on if there are no questions, because you can see by the emoticons that your presentation was really very helpful to all. So we're going to go on to our final presenter, Dr. Wayne Palmer. He will be speaking about the role of ethics in adolescent sports medicine, prioritizing long-term health over performance. Now, Dr. Wayne Palmer is an orthopedic surgeon, and he did his fellowship in arthroscopy, upper limb reconstruction, and sports medicine in the University of Toronto. He's presently senior lecturer at the University Hospital of the West Indies and UWI Mona, and he is head of that division. I must mention that he is the president of the Jamaica Cycling Federation, and we're really looking forward to his presentation. Please go ahead, cycle away, Dr. Wade Palmer. Thank you so much.
Okay, good evening.
Evening, Doc.
I hope that everyone can see and hear me clearly.
Yes, sir.
Okay. All right. I think it's a hard act to follow when you're last on the list and you have so many eloquent presenters. But I'm gonna go ahead and give this a shot. I hope that we have our attentions. So we're prioritizing long-term health over performance. And I think that is something that we resonate quite well with here in Jamaica, as we are a country of high performance. And so that's something that I think everybody can understand clearly. So my disclosures, I am a sports coach, so I am actually on the other fence as well, pushing for performance. And I am the president of the Cycling Federation. And one of the mantras of any sport association is that we get performance. That's really what we're asked to do. But I'm also a parent of athlete children. And so I understand what it is to have adolescents who are performing in high-level sports, and from a parent point of view, what that looks like. And so I want to make these disclosures. But I'm also wearing the hat of a physician as well, and I do see what happens from that side of it. So performance, this is what we're about in Jamaica. And if anyone has gone to Champs, we will kind of see the energy that comes out in Jamaica when we perform and perform at our highest. The same occurs when we get to the World Cup in football, or we get to the finals in netball. We have a certain energy about us, and we are very proud of our young athletes when this occurs. However, I doubt the average person thinks of what goes into the athlete in order for this performance to manifest itself. And some of these things are good, and some of them not so good. So a little bit of background here. Organized youth participation in sports is very popular worldwide. Approximately 45 million youth and adolescents participate in sports in the US, and that's quite a big number. In Jamaica, we also have such a culture of sports performance from a very young age. If you watch the under-20 athletics championships last year in Peru, we ranked fourth, copying quite a bit of medals with our young athletes. And so we're all very proud of this kind of performance. What we may not recognize is that a lot of these athletes are actually out there preparing from a very young age, and also the amount of sporting activities, meaning number of sports and hours that they're participating in sports, are probably more than most of us work in a week. So I'm not saying that there aren't advantages to exercise, as our previous presenters would have pointed out, that we clearly have a problem with activity in our youngsters, in our adolescents. So the clear advantages are the improvement in mental and physical health, the social benefits that they seek, and also the obvious physical benefits, which is both immediate and long-term. However, we ought to bear in mind that physical activity and exercise differs quite a bit from training and preparation for competition. So when we're talking about high-level performance, we're really talking about the latter. We're talking about training and preparation, which goes beyond just physical activity and exercise. So now the latter, which is the high-level performance, which requires training for a specific purpose, carries the greater risk for sports-related injuries, for burnout in the athlete, and for the risk of the athlete doping. Now, sports programs, whether these by schools, clubs, or federations and associations, often are emphasizing success. And so we have to be careful that our sports programs do not overemphasize winning at all costs, because programs that overemphasize winning often see high attrition rates, sometimes as high as 80%. I challenge you to look at the athletes in Champs and ask yourself, how many of those athletes continue to a career in track and field and reach the highest level? Of all the athletes that we see, what percentage of them? And we can say this for almost all sports. If we're pushing them too hard, we tend to get a high attrition rate. And so we have to be careful when we do this. We did a 5-year review of children and adolescents that we saw at the university hospital in the orthopedic clinic. and those that needed treatment by arthroscopic surgery. So we're not even talking about those that needed treatment but not surgery, those that needed surgery. And we found that a large percentage of them fell in this adolescent age group. Average age was about 14. The majority were males, and the majority had knee injuries. And these were almost isolated to sports injuries. So the majority of them were either participating in sports or preparing for participation in sports, and when they sustained their injuries. So let's look at a few definitions here. What is physical activity? Physical activity can be defined as any bodily movement produced by our skeletal muscles that results in energy expenditure. So when we get up in the morning and we walk to the kitchen and we make a cup of coffee, that's physical activity. When we walk outside and we get in our cars, that's physical activity. Exercise, on the other hand, is a subset of physical activities that is planned, structured, and repetitive, and has a final or intermediate objective. So for instance, we may exercise to lose weight. We may exercise to improve our fitness. We may exercise for the health benefits, controlling our blood sugar, for instance. Training, on the other hand, is the action of undertaking a course of exercise and dietary preparation for a specific sporting event or health benefit. And there's often a fitness objective, and this usually is time bound. So we are expecting to achieve these goals within a certain time. We expect to run a certain time by the time we get around to champs. We expect to be a certain speed by the time character trials come in the pool, that kind of thing. So therefore, that adjustment is time dependent, and that perhaps is one of the key components that creates problems. So there are certain risk factors for adverse health in the adolescent athlete. And we might look at these risk factors as intrinsic to the athlete or extrinsic. And so some of those factors are the age. The younger the athlete, the more the risk of developing adverse health outcomes. If their physical development is poor, they're underdeveloped, again, correlating with age, then their risk, again, is higher. If they've had previous or current injuries, then they're at risk for more injuries or worsening of the current injuries. If they have abnormal biomechanics, bow legs, knock knees, that kind of thing, a curved spine, then they're at risk. If their skill level is low, so they're more at risk earlier in the introduction when the skill level is low, as opposed to if they are highly skilled later on. If they have poor physical fitness, so they will get in, start a sport, but the coach needs to get them performing in a short time, so they're really doing a lot of activities, but their physical fitness is not yet at the level that's required for those activities, and therefore that can lead to injuries. One of the key things that we often look at is early specialization. So we're asking athletes to specialize. For instance, the athlete who does track, we're asking them to do specific things. We want you to be a sprinter and do the 100 meter. So they're early specialization as opposed to general exercise. And we find that this early specialization increases their risk. If there's increased training load. Now, I've had a number of athletes come to see me, and when I ask the parents, how often does your child go to training? They say, well, the child wake up in the morning and we have to go for our training before we go to school. And then when school is over, we go for 2 hours in the afternoon. And we do that 6 days a week. And we have to ask ourselves, so how much exercise is that? We're talking about 3 hours per day, 6 days a week, 18 hours. That's a large volume of exercise where's the rest? Where's the recovery? Isn't that too much? So we have to ask ourselves, is the training load too great? Are the environmental conditions poor? Are they playing soccer on a dirt field or a field with holes or a lumpy field? Are they running and training on asphalt or concrete, which is hard? Is the shoe that they're wearing poor? And so the feet are getting more impact than it ought to. Is the child training after the child is fatigued? So they had training yesterday, stayed up all night doing homework or studying for a test, and then afterwards they're going to training again. Is the child fatigued? And so those are key things. Another key aspect is whenever the training is results focused. And what I mean, and everybody will ask, well, don't we train to get results? And that is true. But when we tell the child that you have to win that 100-meter, and so the training is about winning the 100-meter, rather than training, you have to get better, you have to improve your technique. We're looking for you to try and improve your time by 10 seconds. If you don't win, but you achieve that, then that's a good thing. And so we're not looking at the results, but we are focused on the process. And I think that it's better for that. But when we are results focused, where we are looking at winning at all costs, then it creates a problem. We spoke about equipment before, you know, the shoe and the shorts and the various things that are required for the various sports, then that's important. And of course, nutrition. Enough can't be said about nutrition. It's not just what they eat, but it's also when they eat. That may be critical, and your child may not be getting enough before they get into sports. So they're going training in the afternoon and they don't get enough to eat before training starts, or they've done a certain activity, training is lasting 2-3 hours, but we don't break to get a snack or to have a sport drink during the activity. We keep going. And so that can lead to nutritional problems and ultimate injury or harm. So what are some of the common injuries? Well, we do see back injuries, and we tend to see this in athletes who do lifting or jumping exercises, those who do throwing like cricket, fast bowlers, we see that. I see a lot of ankle sprains. But some of the things I want to highlight are those things that push the athlete into major medical treatments, such as surgery. So a bone fracture is going to get you out of the sport for a significant period of time. Or a ligament injury is going to get you out for a significant period of time. And those are some of the things that impact greatly the athlete in both a physical and a mental way. However, there are the less significant injuries that develop chronically over time, and oftentimes the athlete pushes through or is forced to push through these minor things. And these are the tendonitis and the bursitis and the epicondylitis and those strains. So all of those inflammatory conditions where they're asked to, let's just push through it, let's ice and push through. And so that's also a high risk situation. So when we have our athletes and they start to complain of something during training, then that should be a red flag. A red flag, not to push through, but a red flag to have it evaluated so we know what it is. We should diagnose it, and then we know. And this is where our physicians come in. They're going to take these patients to you, and you have to come up with a diagnosis first in order for us to intervene. So some of the sports that are commonly associated with injuries. Soccer, and soccer is very popular here, leads, and I would say not only in this study, but here in Jamaica as well, we see perhaps the most injuries from soccer, and these are usually significant, requiring attention, specialist attention. And then we have other sports that require pivoting, twisting, turning, or contact, like judo, basketball, volleyball, and then athletics to a certain degree. And so we have to focus on these particular activities, the ones that are highly popular. So the athletes not only train, but they go home and they play more football. And so we have to be careful of those because, again, the number of hours that they participate in these activities or train correlate directly with injury. And then, of course, apart from the physical injury, there is the mental impact. So a greater burden of health problems are associated with athlete burnout. So if the athlete sustains multiple injuries over time, that has a negative mental impact. But also if the athlete participates in training of a certain intensity and volume, training load, over a period of time without significant rest, that also leads to mental burnout. And so we have to look for that because it comes in various forms and sometimes it's very subtle. So more frequent and severe injuries are a sign that we should look for our athletes and look for the mental impact. Now, we did a study on athletes who had ACL injuries, and we did an ACL reconstruction at the university hospital. And what we found was that there was a negative impact. Even after we fixed the ACL, rehabilitated them, we did an assessment, found that they had achieved the physical requirements to return to sport. A lot of them still did not return to sport because of fear of re-injury. It's almost as if they had a post-traumatic stress. They wouldn't trust the knee. And so there was a fear of returning to sport. And that fear impacted their physical activity level. And a lot of them didn't go back to sport, or they three months in most instances before they were able to get back to sport and perform in any meaningful way. And so that was important. The other aspect has a page on its website dedicated to doping in youth sports. And that's because of the frequency of doping and its increasing frequency in underage athletes. Now, under the strict liability principle, an anti-doping rule violation occurs when a prohibited substance is found in an athlete's bodily specimen. And this violation occurs whether or not the athlete intentionally or unintentionally used a prohibited substance. And so this is something that you might believe only impacts adult athletes. After all, we only hear about positive tests in our adult athletes. However, one of the things that I think that we sometimes forget is that a lot of our youth athletes are taking supplements. Now, supplements are often implicated in doping violations and are very popular among athletes. I would say a large percentage of doping violations are related to supplements. There's often the misplaced perception that supplements are necessary for high performance. Now, a study done by Gear in 2004 looked at supplements and found that a high percentage of supplements had what was reported to be contamination, and that contamination is often with anabolic steroids. So the supplement, the package does not state that there's anything that is banned within the supplement. However, during the processing protocols, something gets in there that's banned and then it's picked up. The US Anti-Doping Agency evaluated 171 products, and that represented about 10% of mainstream supplements, and found out a staggering 2/3 of them contained at least one prohibited substance. And this was mainly steroid or stimulants. And that's quite alarming. And we get a lot of our supplements out of the US. In Europe, they looked at schools and did a survey on alcohol and other drugs in schools. And out of 96,000 young people in 35 European countries, they found a 1% of students were doping. The highest was in Bulgaria, about 4%, and males were frequently the ones attempting doping. And so you might think, well, this is in Europe and the US. But we, in Jamaica, there was a study that was done by Turfus et al. Out of the sports medicine clinic on the university campus. And they look at supplementation practices, perceptions, and knowledge about anti-doping among Jamaican high school athletes. And so these were athletes aged 12 to 19 years, and they were attending after-school training. They interviewed about 127 athletes and found that just under 60% of them had been taking supplements. The majority of those were athletes training for champs. So most male athletes and champ athletes were more likely to obtain supplements from their coaches. So again, it's not just the athletes, their coaches are promoting that supplements should be used and that it is necessary for performance. 37% of those athletes thought that the supplements would increase their sport performance. And so this is something that we have in our country and we should look at more closely, because it certainly is going to become or has become a source of concern. Now, what is the impact of doping on our athletes? Well, there's organ damage, and the primary organs targeted are usually liver and kidney. There's the negative impact on growth, and some of these substances may cause premature physeal closure, and so stunting of growth is one of the impacts. There may be abnormal development, disruption of puberty, aggressive behavior or abnormal sexual behavior. And if this substance is withdrawal suddenly, they may develop depression and may even become suicidal. So there are both physical and psychological impacts to doping in the adolescent. And so, again, we have to be careful. So what or who drives this problem? Well, the problem is driven certainly by a number of facets. The parents who are wanting to see their child successful, or a parent who is living vicariously through their child. Or maybe there is some financial gain for the parent if the child is successful. And then we have the coaches. The coaches may want success for the team or the school, or there may be some personal gain for the coach, maybe financial, or just wants to know that he's the best coach. And so sometimes there's that extra push above and beyond what is best for the athlete. And then we have society. There's peer pressure. Your friends are saying, we are doing well, we're on the team, and you're not on the team. So there's peer pressure. There's institutional pressure. The school is doing well, you need to give the school points at champs. Or the club is going well, you need to give the club points, or the club is depending on you, you're the anchor man, that kind of pressure. And then the athlete themselves may put pressure on themselves. They may idolize other successful athletes and say, we want to be like that at all costs. They're not wanting to let down parents, coaches, or other personnel. And of course, they wanting to be the best at what they do. And so these are some factors that drive the problem of performance at all costs. So what should really be the fundamentals of youth sports? How do we balance getting the adolescents involved in sport, getting them involved in healthy competition, but not going above and beyond where that now impacts the well-being of the adolescent. Well, we should look at the 3 Fs. We should do it for fun, we should be focused, and we should fuel the basics. So what we want to engage the physical activity. Even if it's competitive, it must be fun. And so we need to make the activities fun. When the activity is fun, we know that injury rates are reduced. There's increased enthusiasm and eagerness of the athlete to participate. If you notice your athlete is no longer eager, no longer interested, don't want to go to training, then that's a red flag. It prolongs the involvement of the athlete in sport, and therefore the dropout rates are reduced, and therefore the lifetime benefits are improved. If we focus on the exercise, on sportsmanship, friendship, and the development of skill, then these are all positive attributes and life skills that will always work to the benefit of the athlete, as opposed to a focus on results or on winning. And again, we fuel the basics. We keep it simple, so it's not a complex, hard-driven activity. We reward the effort rather than the results, and we have an athlete-directed goal. So here are some guidelines. I think that it is crucial that we have pre-participation evaluation and re-evaluation. So we should be evaluating every year, annually, these athletes before the season starts, before they get active. We need to reinforce the things that are going to lead to adverse health outcomes. And all should be involved in this pre-participation evaluation. Parents, athletes, coaches, and other allied persons, institutions if necessary. And this should be a standard of care. If issues are identified, then early referral to sports physician, psychologist, nutritionist, whichever arm of healthcare is needed to address the problem. And I think that if we do that early enough, we can actually avoid the health injuries that will occur later. These are some of the resources where, I'm sorry, let me just get back to that. Yeah, these are some resources we can go to. So the American College of Sports Medicine has a document on physical activity in children and adolescents, and that's on their website. World Athletics has a document on special consideration for child and adolescent athletes. And pre-participation evaluation, physical evaluation, there's a document on the American Academy of Pediatrics site, but there are several other sites where we can get a pre-participation evaluation. Not just that, we can actually get a pre-participation evaluation sheet that we just simply need to go through and fill through. And so it allows us to screen through these athletes and pick up any problems from early. So in summary, exercise has clear health benefits for the adolescent, but caution is needed when the athlete begins to prepare for high-level performance. Risk of physical injury and negative mental effects are more likely with male athletes, high training load, and when training is results-oriented. The pressure of high performance increases the likelihood that the athlete will use supplements and other methods that will risk an anti-doping violation and secondary negative impacts. We should focus on the process, add fun as a factor, socialization should be key, and look at positive health benefits. Acceptance of successes and failures in competition should be something that should be at the fore prior to competition, so that the athlete knows how to respond to both successes as well as failures, particularly failures. Develop long-term goals within and outside the sport. So the development of long-term goals helps the athlete to recognize that results now are not critical, but the process is critical. And once we go through a healthy process, then the results and successes will come. And that sport is not everything, but health is everything. And again, my final push, annual pre-participation evaluations, we should insist on it. It should be a standard. These are some references. Thank you. Any questions?
Wow, what a very comprehensive, hands-on presentation from Dr. Palmer. We feel very helped. Certainly as family physicians, we do have athletes coming in from the school to our offices. Often the coach trying to do his best, picking up the injuries late, I'm afraid, or the recurring injuries. And then as family physicians, we're asked to intervene. And I think your such strong suggestion for a pre-participation evaluation is very important. And we'll certainly go to that website to look at the form. Very hands-on. Questions there are. Let's see. I'm going to put in my questions first. I'm being selfish. You mentioned supplements, danger there because of contaminants. What about multivitamins, which often their relatives abroad or their parents have bought? What is the importance of multivitamins to these young athletes?
Well, first thing, I refer to the WADA mantra on supplements, and these include multivitamins as well. And the first of their recommendations is a food-first approach. And so if we are feeding our athletes healthy, if we are having any challenges and we suspect that there might be a nutritional issue, then I think the first thing should be to have the athlete see a physician. Let the physician then determine the need for any kind of supplements, whether that be vitamins or anything else. I think that's the ideal situation. And I dare say a nutritionist is probably the ideal person in order to determine the need for these. Because even in vitamins, and particularly those coming out of the US, may have substances that are contaminating.
Thank you. And we need to teach our clients, their parents, their coaches about this danger. Thank you so much. Well, Modupe has a question that he wants to pose. He says, are there any considerations using similar or the same techniques to motivate and improve other teams' productivity and focus academically? So he's moving us from sports. Any comments there before we go on to the next?
I'll just quickly say that a focus, if you look at athletes that have poor academic performance, that have been put in a sports program that focuses on health and development and a structure, that their academics actually improve. And that is because sports itself can build discipline. And so if we focus on that aspect of it, it can actually improve and spill over into the academics as well.
Thank you. Excellent answer. Dr. Rhonda Hudson says, thanks, Dr. Palmer, for an excellent presentation. This is to inform all that the Jamaica Association of Sports Medicine does evaluations of high school student athletes to include examination, functioning tests, musculoskeletal examination, and an ECG, all free. We do this by counties we will next be doing this in Montego Bay for Cornwall in March.
That's true. They have been very active in pre-participation evaluations, and we have to give them thanks. And again, if we pick up that athlete that they have missed out, then we would ask that, that's a resource that we could actually refer to. Absolutely.
So we should, yes, that's an important referral. College and Rhonda Hudson as the evaluations as the PHEs. What is that? I'm not sure. Capital P, capital H, capital E. Physical health exams or something.
Exactly. It's a pre-participation evaluations that she's referring to. Yeah.
Thank you. Carlette Jarrett, I also suggest each athlete do an ECG yearly in the pre-participation. So we had mentioned that previously by Dr. Hudson. Is there a role for an echo, Dr. Palmer?
Well, in some jurisdictions, they actually do screening echoes because it is thought that ECGs may not be sufficient for screening, but I don't think that that's widespread accepted. I think that physician evaluation and your ECG, and then if you pick up, then we can proceed to things like an echo.
An echocardiogram. And somebody asked, Joseph and Edu, how do we get this type of lectures directed to the coaches and parents?
And I think through you, through your organization, I think we can, even if we organize sessions, we'd be willing, I'm sure the Sports Medicine Association will also be willing to give talks to coaches, which they do from time to time as well. Yeah.
Excellent. Tracy Lumley asks, wonderful presentation. Is there any standardized government-sponsored and subsidized nutrition program for the athletes?
That I'm not sure of. I'm not sure if there's a government subsidized nutritional program for athletes. That I would have to check. I'm not sure.
Okay. Well, we really want to thank you for, as I said, very pragmatic, very hands-on. This is something we will do tomorrow morning when the athletes walk in. And we do want all our clients, our young clients, to be involved in physical activity and exercise. Absolutely. As you pointed out earlier. Yes. Maybe not training for high performance. Really want to thank you for this, Dr. Palmer. And you didn't tell us you're also in the private sector, or you're only at university?
No, I'm in private practice as well.
All right, so we can find
both private and public.
Great. So for those who are very, very concerned about their CMEs, because you're getting 2 hours of ethics and 2 hours of mental health, Dr. Palmer, in the role of ethics in adolescent sports medicine, has given us our credits. Dr. Anthony Francis spoke of ethics of managing substance. So that's our 2 hours of ethics. In the terms of mental health, Dr. Abigail Harrison spoke about body image and self-esteem in adolescents. Professor Carol James did managing anxiety in adolescents. And of course, Dr. Miller as well spoke to us about, Baldwin Miller spoke about the intersection of mental health and substance use. What a wonderful feast. We have spent about 4 hours. I think the presenters were excellent in that they kept to time and they answered our questions. I really want to thank our the Caribbean College of Family Physicians for designing this webinar. It was well thought out. They had excellent presenters, and the technology allowed us to interact and to have our questions answered. Thank you so much. Just want to remind you that you'll be getting your 4 CMEs. The technology will handle it. You signed up, you registered, you paid for the 4 CME, you will get your CMEs in due course. Thank you all. Have a very pleasant evening. Sam, the final word is yours. Is this anything else?
No, I actually think the final word was supposed to be for Dr. Levy. Dr. Dane
Okay.
Levy was going to be doing the vote of thanks. But you did a wonderful vote of thanks. And we're going to let everybody get out of here and go and have a
Dr. Dane
feast of
Levy,
a dinner. Doc, you there?
if you wish, yes, go right ahead. Let me leave you.
My duty is very short. Good evening, everyone. I just want to thank Pauline, Dr. Pauline Williams Green, for doing a very able job, including doing the vote of thanks. It was a wonderful exercise in moderating this wonderful webinar. But let me just highlight for myself, I think I would want to, on behalf of our President, Dr. Seni Ananujo, I think would have probably done the opening remarks, and one of my colleagues would have prayed. I want to thank all our presenters, Professor Carol James, Dr. Frankson, Dr. Miller, Dr. Baldwin Miller, Dr. Abigail Harrison, and last but by no means least, Dr. Wayne Palmer. All wonderful presentations, and very, very thankful also to our very able facilitator, Sam Heron, of Old Gate Solutions. Sam, you also did a very wonderful job in guiding us through this webinar. And Pauline, you said it took up 4 hours of our Sunday afternoon, but it was well spent. I got home from church and I wasn't even able to change because there's such an enthralling presentation, one after the other. The questions from our colleagues who participated, also very interesting questions and well answered, well tackled, and well addressed by our various different presenters this evening. So thanks once again to one and all. I saw a few names that remind me of my colleagues from medical school. Special shout out to you. And thanks again to the Caribbean College of Family Physicians in putting on such a wonderful webinar this afternoon, particularly our President, Dr. Sene Ananuja. Thanks again. God bless you all.
God bless you too, Dr. Levy, and thank you to everyone. Please stay safe. Have a wonderful evening. You see the information here on how to get your CMEs. Of course, please make payment. Some of you already have, and we thank you. But remember, once you make those payments, we may see that payment as hit the account, but we'd like to also know who you are. So please copy your proof of payment, send that email off to the CCFP Secretariat at ccfpsecretary@gmail.com, and that will qualify you for your CMEs, as you've already attended here, and you would have, I'm sure, attended for the 75% of the time that was required of you. Ladies and gentlemen, what a feast it really was. Thank you, Dr. Williams Green, for your moderation and all the presenters. Have a wonderful evening. Stay safe.